Welcome to the final day of the Preconception Coin Show Your Love Initiative Future Forward National Convening of Equity-Centered Women's Wellness. This is the last of our 3-day virtual conference experience, and we're so grateful that you're investing your time with us today. Across this conference, we have had the opportunity to dream, reimagine, synergize, co-create, share information, learn with and from each other, and chart the course forward in preconception health. Thank you again to all who have joined our space on September 1st and 2nd, and please know that you will receive an email for recordings, graphic notes, and so much more in the coming days. My name is Ana Cabello de la Garza. My pronouns are she, hers, and ella. I am an immigrant, public health social worker, scholar, daughter, wife, friend. I have the dear honor of serving as chair of the consumer group for the National Preconception Health and Healthcare Initiative. And I have the great privilege of navigating through today with you all as your MC. I'm going to ask the rest of the team to turn on their cameras and wave. Sarah, Erin, Catherine, and Suzanne. Now, for some important thank yous. We would like to show our love to our amazing dream team. Eilish Neely, Shamika Tomlin, Jessica Haynes, Kennedy Bridges for supporting the conference, as only you all can do, as the official Show Your Love squad. We're excited to have Rio Holiday join us today as well. I mean, have you seen what she can do? She's absolute magic. She will be serving as our graphic facilitator who will be listening to the conference sessions and taking live graphic notes to beautifully and powerfully capture our hopes and, most importantly, our next steps. We also want to wholeheartedly thank the UNC School of Social Work for the technical support. We really appreciate y'all for making our experience easy and fun. We are grateful to our speakers for sharing their insights with us. Please note that if you're curious, you can learn more about them and their prolific work in the speaker section of the conference hub. Check it out. Registration is staying open if others would like to join last minute for this or a future date. By the way, please know that on the hub, we have also included a Jamboard for attendees to post inspiration, thoughts, ideas, as well as challenges. This is your space. If by any chance you're experiencing technical difficulties, please email Catherine Bryan. We'll put her contact info in the chat. Now, let's talk about interactivity throughout today. There are a few ways that you can engage with our speakers and others during this conference. That can be via chat, via small group breakout groups, via Jamboard, even through social media. If you're going to use social media, we ask you to please share posts with the hashtag #ShowYourLoveToday. This is the Show Your Love Consumer campaign, and we're excited to use their hashtag to share important messages that resonate with you and yours during these sessions. Now, and to making sure that we're doing the right thing and doing the thing right. We have an evaluation survey for each of our sessions. Please fill it out. Your feedback is essential. For some truth telling. Some of us are settlers, some of us are immigrants, and or descendants of those who were forcefully brought here to this land. It is our collective responsibility and call to action to reckon with our past, pay respect to this original land and its original inhabitants, as well as do better together moving forwards. We offer gratitude for the living legacy of these communities and commit to honoring this land and its First Nation folks for their infinite contributions, past, present, and future. Please take a moment to consider the many legacies of resilience, violence, displacement, erasure, migration, and settlement that have led us to this very moment. I would also like to offer glory and honor for those who are not here today, especially those who we have lost because of this pandemic. We dearly cherish their memory, and we are here to do better and remember, to reverently commemorate the ancestors who dedicated themselves to reimagining a brighter future, especially those that work so hard for communities that have been systematically decentered. We are here to learn and unlearn and thus actualize our potential, to mourn and grieve who and what we have lost. Actually, did you know that in Spanish, the word to vent doesn't really translate well? Rather, we use the term desahogar, which translates to the concept of undrowning yourself. So let's take a deep breath, let it out, be here now. Thanks for taking a moment to collectively acknowledge our grief. Because multiple things can be true at the same time, we're also here to celebrate the alchemy of our collective dreams, our power and action. So let's do a centering exercise so that we can get ready for today. I invite you to close your eyes or lower your gaze. Bring your awareness inwards and focus on your breath, in and out. Now, I invite you to visualize someone you love and repeat the following phrase silently. May you leave with ease, may you experience joy, may you be free and in a state of wholesome wellness. Then visualize someone who you're acquainted with, who provokes a neutral feeling. Repeat the mantra. May you live with ease, may you experience joy, may you be free and in a state of wholesome wellness. Then visualize someone who you may have a conflicted feeling towards. And repeat the mantra. May you live with ease, may you experience joy, may you be free and in a state of wholesome wellness. Now visualize all living beings, including yourself, and repeat the mantra. May you live with ease, may you experience joy, and may you be free and in a state of wholesome wellness. When you're ready, bring your attention back to the present moment. As we get ready to launch all the wonderful things that we have in store for you today, I invite you to nurture and nourish yourself throughout our time together. So on that note, let's get to know each other. In the chat, please share your name, pronouns, where you're from, and what is your purpose today in being here with us. I would really love to know what are your intentions for our time together. And this will also help our speakers contextualize their stories and what they share with us today. While you're talking about what your hopes and dreams are for our time together, it is my great honor to kick off our first session. Our first session is titled Revisiting Preventive Visits for Women as a Title V National Performance Measure and a Unique Opportunity. For context, this session will be about how the Maternal Child Health Block Grant got started as a program. This is a federal state partnership with the goal to support health and well-being for all mothers, children, and families. Several years ago, a new national measure was introduced. It was called Increasing Preventive Visits for Women. This session will offer a quick overview and some status updates. Then the speakers will share some ideas about innovations underway that will support a sister measure, which is called Increasing Adolescent Well Visits. The group will then talk about opportunities for innovation and leadership in this space. Now, I'll pass the mic to our panelists so that they can introduce themselves and get started with this conversation.
Hi, this is Carrie Ann Uesugi. I'm sorry, I lost my full screen. Do you want me to just do my slides or let Mch introduce themselves?
Perhaps you can introduce yourself and Team Mch can introduce yourselves, and then you can jump into your slides.
Hi, my name is Carrie Ann Uesugi. I work for the Maternal and Child Health Bureau and the Division of State and Community Health, which administers the Title V Block Grant Program. I am a health scientist, mostly responsible for putting together the federally available data, which includes the National Performance Measure 1 that I'll be talking about in a minute.
Hi there all. My name is Andrea Cornell. I'm the Associate Director for Women's Infant Health at Mch, the Association of Maternal and Child Health Programs. It's a real pleasure to be with you all today. I'll pass the floor over to my colleague, Janina.
Hi, everybody. My name is Janina Ong. I am the Maternal Health Program Associate at Mch, and I'm happy to be here today. I will pass to Christina.
And greetings, everyone. Once again, my name is Christina Wint, and I'm the Program Manager for Women's Health, also at the Association of Maternal and Child Health Programs. So happy to be with you guys today. Back to you, Carrie Ann.
Thanks, Christina. I'm going to share my screen now. Okay, so today I'm going to be giving you a little bit of background into NPM1. as soon as there we go. So NPM1 is the percent of women aged 18 through 44 with a preventative medical visit in the past year. This measure comes from the Behavioral Risk Factor Surveillance System from the CDC. This measure is also shortened to often Well Woman Visit. And the concept of this measure really does encompass related things like pre and interconception care, but it also captures women who are not planning or post-pregnancy. So a lot of the things that we've talked about in this conference in sort of encouraging wellness across the lifespan would be encompassed within this NPM1. Thinking about how we frame it in our guidance for the Title V Block Grant Program, we think of this Well Woman Visit as an opportunity to provide a critical opportunity to receive recommended clinical preventative services, including screening, counseling, and immunizations, which can lead to the appropriate identification, treatment, and prevention of disease to optimize the health of women before, between, and beyond potential pregnancy. So potential, they may or may not have a pregnancy during their life. We do say that this NPM is linked to several of our national outcome measures, including severe maternal morbidity, maternal mortality, a lot of adverse birth outcomes like low birth weight, preterm birth, early term birth, and then as well as various infant mortality outcome measures. It's also related to maternal behaviors during pregnancy, like drinking during pregnancy, as well as substance use, which is operationalized as neonatal abstinence syndrome for the most part. So that's a definition of it. To give you a brief timeline, I want to shout out to Kay Johnson for providing the far more comprehensive timeline of the concept of preconception health. I really did appreciate her talk during the first session. And if you hadn't seen that one, I would recommend you do that. This is far more abbreviated, focused on Well Woman Visit as an NPM. To begin with, the Affordable Care Act passed in 2010 had that focus on insurance covering preventative services, including annual physicals. In 2011, the Department of Health and Human Services commissioned IOM, which is now the NAS, a study on the initial recommendations on women's preventative services guidelines with a recommendation to update them every 5 years. So that was the first set of women's preventative services guidelines. In 2015, we underwent a Title V maternal and child health block grant transformation, where we created a whole new performance measure framework. And that's when we established NPM1, Well Woman Visit. In 2016, HRSA, which is my agency, entered into the first 5-year cooperative agreement with ACOG and others to update the Women's Preventative Services Guidelines as part of the Women's Preventative Services Initiative, otherwise known as WPSI, which you heard about in the first or second session, I believe. And as of now, we are now looking at updates for WPSI, particularly on the Well Woman Visit. And there is an actual public comment period that people can comment on the draft language for the updated Well Woman Visit recommendation. So how did we come up with National Performance Measure 1? At that time, we wrote about the new performance measurement system. And you can read this paper that's cited here at the bottom, which is a really nice overview of the performance measurement system and sort of the criteria and the thinking around the new performance measures. So I've drawn a lot of these bullets from that article if you want to read more in depth. But in general, Well Woman Visit is consistent with MCHB and the Title V legislation's focus on preventative health services. There was also that emphasis, as I mentioned, within the Affordable Care Act on women's health preventative services. When we're looking very minutely at which measures would be good, we had several criteria. One is that it had to be nationally available with annual data, available to be broken down at the state level, and by various demographic stratifiers in order to identify disparities. That's something that often gets overlooked about our national performance measures. I think if you go to our Title V information system, you see the the measures presented for overall, but we do annually break down and provide stratified data for all of our national performance measures as the data source allows in our federally available data source resource document that's also available on our TVIS website. NPM1 also fit in with the life course perspective that Dr. Michael Liu, who was our previous MCHB administrator, was a big champion of, and it's still a fundamental framework for a lot of our MCHB work. It also fit into this new population domain concept where we have 5 population domains: women maternal health, perinatal infant health, child health, adolescent health, and children with special healthcare needs. So this was a very uniquely women maternal health measure. The old performance measures, for those of you who may have been part of Title V pre-2015, we did have performance measures, but they focused on pregnancy. There was early entry into prenatal care and smoking during pregnancy. There wasn't one related to women's health in general. Going back to that life course perspective, another one of our NPMs for the adolescent health domain is adolescent well visits. So again, this is a very nice alignment with Well Woman Visit. We want our adolescents to be getting regular care, and we want that to transition into regular adult well woman care. And lastly, the one criteria was that it had to be considered modifiable by Title V activities. So since we've implemented NPM1, we did hear challenges from the states and other stakeholders. Some challenges were that NPM1 or Well Woman Visit didn't immediately align with the existing maternal health activities that Title V agencies were engaged in, such as prenatal care, smoking cessation during pregnancy. Another challenge was identifying the research on evidence-based strategies to improve well woman visits. The Mch Evidence Center is a TA resource center focused on helping states identify evidence-based strategies to address these national performance measures. And when they did their evidence review, there was not really any strong research conducted around strategies to improve overall well woman visits. So they drew a lot of their strategies from the research related to preventative services, cancer screenings and other types of screening services. So that's still a struggle that I believe is out there. Even if you look at the WIPC background research on well woman visits, it's again acknowledged that there's not a lot of research focused on ways to increase well woman visit rates. Another challenge that our AMCHIP colleagues will probably be talking about is this notion of what to focus on with well woman visits. When we implemented the measure in 2016, we saw that a lot of our evidence-based strategy measures were related to the quality of a visit, and we couldn't immediately see the connection to how this was going to increase access or increase or be able to improve the national performance measure. And there were lots of questions that have come up related to what makes up a well woman visit, who provides a well woman visit, sort of open-ended questions for states to grapple with. We did hear a lot of these challenges, and in 2018, we made adjustments to our national performance measure framework in that set of guidance. Before, we had a life course domain or a cross-cutting domain, and we still have a cross-cutting domain, but in 2018, it was, we took out all the national performance measures associated with it and redistributed them amongst the other population domains. So we were able to add smoking during pregnancy and preventative dental visit to the women maternal domain, just to give some more options for states to choose different types of women maternal national performance measures. We also reduced the number of national performance measures that were required to be selected from 7 to 5. We made state performance measures optional, but we do require a state performance measure if the NPM is not aligned with the priority need that's identified by the state. We also reiterated that the priority needs should drive the selection of the NPM. One thing we saw in 2016 was that a lot of states just based their priorities on which NPMs they could select. One change that we've done in this new guidance that was released in January of 2021 was that we revised the ESM detail sheet, which is the evidence-based or informed strategy measure detail sheet, which now we're asking for states to more clearly define what the evidence-based strategy is. We're also asking states to more thoroughly explain how their strategy and that measure is going to impact the national performance measure. So helping states to really think through, okay, if I'm working on quality of the well woman visit, how exactly do I theorize that will improve the national performance measure? So that's a new change that we hope that we will be reviewing in this upcoming block grant review season. And I apologize for those of you who may be attending that aren't as familiar with Title V or the Title V performance measurement framework. You can always go to our website, which is, I'll put in the chat box at the end of my presentation and you can read more about it there. Just to give you a sense of where we are currently with NPM1, this is a nice map that the Data Resource Center on childhealthdata.org puts together every year. They present the statewide estimates for a lot of our national performance measures, including NPM1, and they show where that state is in relation to the overall US total. So 47 states selected NPM1 at the beginning of this new 5-year cycle last year. I checked recently with the new applications. States had the opportunity to change their performance measure selection because of the pandemic and a lot of issues that might cause changes in priorities, but the same number of states continued to select NPM1 this year. I unfortunately didn't have time to add the jurisdictions, so I included them there. We had several states who, and I've highlighted it with a red star, who selected NPM1 and their priority need had a health equity focus. So I wanted to highlight that here because this conference is focused on equity. As I mentioned, we do provide the data stratified across various demographic stratifiers. So I wanted to present what the overall disparities look like among well woman visits. Among race and ethnicity, Hispanic women had the lowest rate of having a preventative visit in the past year. Non-Hispanic Black women had the highest rate. Rates increased with increasing educational attainment as well as household income. The big disparity is between insured women and uninsured women, as well as English speaking and non-English speaking women. And there's a slight increase, but the difference is not terrible amongst age. I do want to point out that I was looking back at the Kaiser Family Survey from 2017 on women's health, and the order of which these disparities occurred was very similar for race, ethnicity, educational attainment, and household income. So what is the future of NPM1? Since we just completed our first 5-year cycle in 2020, we wanted to take that time to accumulate 5 years worth of data across our NPMs so that we could evaluate how well the performance measure framework was working, whether or not changes in the states were able to make progress in the NPMs. So that's something that's going to be ongoing over the next year or two. We hope to complete the evaluation so that we can begin to consider any revisions to our national performance measures. We didn't really make any revisions in this last guidance release at the beginning of the year, but if we are making revisions to our national performance measures, that will likely happen for the 2024 to 2026 guidance, 3-year guidance. So that's all I have today. I will turn it over to Andrea now.
Thank you so much, Carrie Ann, for that detailed presentation. So greetings all, I'm Andrea Cornell. I'm joined today by my colleagues, Christina Wendt and Janina Ong from AmChip's Women's and Infant Health team. We're really excited to be with you to talk about the Title V National Performance Measure #1 and to enter a brainstorming space. So our presentation is really to give you some brainstorming nuggets overall in what it means to work through this national performance measure. I do want to just acknowledge, to Carrie Ann's point, we started today and this presentation in a lot of like administrative weeds related to a key aspect of the Title V MCH Services Block Grant. But for those of you that are unconnected to state or jurisdictional governmental MCH or the Title V Block Grant itself, I hope we'll illustrate some leverage points and partnership opportunities with your state health agencies, especially if anything that we share or that comes out of the brainstorming from the expertise of this larger collective participant group is inspiring or innovating. We really are excited to go in that direction. So if the team wouldn't mind pulling up the slides, just a couple more comments on this first slide. I just want to acknowledge, since the creation of this national performance measure, AmChip has had many interesting conversations and provided technical assistance to our members on how to best leverage this national performance measure to respond to state priorities. And much to what Carrie Ann shared, the common thread has always been that there's tremendous variability in how MCH programs actually approach this measure. That variability is good, and it signals how Title V funding can adapt to the priorities of each jurisdiction, but it also reflects challenges in maximizing the potential of the national performance measure and the strategies to support it, really from the perspective of advancing access to whole person, equity-centered preventive healthcare. And so really, given that a significant majority of Title V programs select National Performance Measure #1 as a focus, and that we have so much room for improvement as a nation in well woman care, we wanted to share some opportunities we see ahead for this national performance measure. And we'd like to use this space to illustrate some pathways to equity for this measure. So next slide. Right now, when we look across the strategy measures for this national performance measure, we see a lot of strengths, but we also see opportunities for better alignment between those strategies and well woman care, the intent and the actual measure that is encompassed within national performance measure #1. In Carrie Ann's presentation, she shared that MCHB prioritized creating a national performance measure on what could be truly modifiable by Title V. And so what we want to underscore here is that Title V has unique power that is different, but complementary to that of clinical partners. There's a flexibility to Title V to fit in those areas where responsibility for our fragmented healthcare system is really unclear, and where we lack joint accountability for systems that ultimately support wellness. Title V is just such a powerful partner. And most importantly, Title V can also be a model for how to lead from advancing health equity and reducing the disparities that Carrie Ann shared. So we know that while the Title V MCH Services Block Grant and the federal state partnership, it's a large sum of funds, it's finite and it covers a large population and a vast array of work. That finite amount of funding, yes, only goes so far, but at the same time, the partnerships that state and territory MCH programs have are just so extensive. And so there's that power, not just in the funding, but power in the relationships that Title V has the opportunity to leverage. So in the space of considering unique roles for Title V, our team, we wanted to share some just exploratory conversations and considerations. These aren't meant to be all encompassing. They won't cover all the wonderful concepts that have been shared in the first 2 days of this convening, but they're meant to kind of keep us in the space of innovation, going upstream together, to use a phrase that Dr. Warren uses often, and just to enter that space of exploration together and see how we can release some of that potential of this national performance measure and the strategies that can be implemented under it. So with that in place, I'm going to now pass it over to my colleague, Christina, to bring us deeper into the space through the next slide.
Thank you very much, Andrea, for setting up that context. As Andrea just shared, we want to spend our time today grounding our conversation in 4 questions. And we'll be using examples of evidence-based or evidence-informed strategy measures to go deeper into each of these questions. And so they're on the slide, but to share them out loud with you all, we want to explore who is providing well woman care. What is, or rather, what do we mean by access? Really thinking and expanding our minds beyond geographic access. We want to think about what is an equitable approach to family planning. And lastly, we want to think about how Title V can leverage the state performance measures and the cross-cutting domain to advance equitable and person-centered wellness. As Andrea shared, this really is a brainstorming space. We're going to kind of talk through some of these questions, but we really encourage you to join us in this discussion in the chat and to respond and to share your reactions and your responses or further questions that will pop out to you as we have this conversation. If we could go to the next slide. So the first question, who provides well woman care? So when we look across the evidence-based measures, we see references to a wide variety of providers, all providing one aspect of care, be it family planning or behavioral health screenings. But there is quite a bit less emphasis on ensuring that people who are assigned female at birth are receiving comprehensive care that is captured by the Well Woman Visit. And so we want to ask ourselves, who can provide this care, this comprehensive care? And who do women and people assigned female at birth trust to provide that care? And as we think about, comprehensive care, we're also thinking about quality care. If we can go to the next slide. And here are just some examples of ESMs that kind of encompass this. And so first here we have the number of women ages 18 through 44 with a past year preventative medical visit in a state health department local health unit. Another example being the number of behavioral health providers trained in pregnancy intention assessment. And when we think about, these measures, and then also, what is comprehensive care and who is providing that? We want to think about and consider, what are the resources that are already being invested in, that are already being seen? Where is the focus on providers and the folk who are already funded? How are the ways that we can reach other people, both patient and provider? It's also important for us to think through, how can we lift up, various types of providers, thinking about federally qualified health centers. When we think about the midwifery model of care, and midwives, a great example, because they are providing care across the lifespan. When we think about other forms of nurses, family providers. How are we supporting these types of providers? How are we reinvesting into community so that they can have a community of providers around them? Next slide, please. And this next question is about what is access? And again, expanding our minds beyond geographic access. We often think about healthcare access as really being geographic, thinking about transportation, maternal health deserts. But there are a number of factors that really impact people's abilities to access care, but also to want to access that care and to feel safe accessing that care. And so we pose the questions of what resources exist in a community with a healthcare provider shortage. If there is nowhere to access, your primary care, how can you leverage what resources you have to ensure that you can remain healthy and stay healthy? Where does cultural congruence and respect fit into the concept of access? It's one thing to say that there is a clinician or provider within your neighborhood or community, but is that provider culturally humble? Do they have an understanding and respect for your cultural practices, for the choices that you make? How do we lower barriers to access for these appointments? And this is a very important one because, again, often when we think about access, we're thinking about geographic. Is there a provider in this neighborhood, in this community? But we also need to think about, the transportation, the childcare. Are people able to get off work in order to make the space for an appointment that may, start late and run long? How are we providing access and lowering the barriers for these types of appointments? And also, are you able to build a trusted relationship with your provider? Are you able to receive continuous care with them, to talk with them, for them to get to know you and you them, and to really trust them with your health? Next slide, please. And the ESM example that we have here is the percent of family planning visits that occur via telehealth at pilot sites is what we saw at a state. And this is a great example because telehealth has really expanded how care has been able to be provided, especially over this past year, as we think about how many places are flexing and reacting to the pandemic. However, it would be remiss for us not to think critically about the limitations there are to telehealth. For example, it's not possible to do a pelvic exam or a breast exam via telehealth visit. And so really, is this, the true solution to, increasing access to well-woman care, or do we have to continue to expand and flex and think about how we can decrease the barriers to people accessing this type of care? I'm sure some of you may have even experienced over this past year with the spread of telehealth that there's a wide disparity in how people are able to access broadband or fast internet. If they even have, a device with a camera on it, a high quality camera where they can talk to and actually interface with their provider. If they, again, have the time to step away and take it to have those conversations. And so these are all the things that we continue to want to prompt you all to think about, and that we want to continue talking about as we think through, what access looks like, how can we decrease the barriers to access, and what we can do. And I want to pass to my colleague, Janina, for the next slide.
Thank you, Christina. I want to talk about how we can equitably include family planning in this, because I notice a lot of ESMs throughout the states include family planning, and I want to think deeply about, considering racist histories of birth control devices while we, provide the best care. So one thing that I want to think about is emphasizing listening to patients and their preferences. In particular, if we are uplifting autonomy, like patient autonomy in birthing spaces, we should also uplift that same autonomy in all patient interactions. But unfortunately, we still find some family planning providers and even general practitioners who provide, counsel about birth control that doesn't respect patient preferences. In particular, sometimes, providers may choose not to hear women and those who are assigned female at birth when they declare that they're using contraceptive methods that are not a LARC or a medication. So, things like the rhythm method or things like condoms, like they may not choose to hear that, and they may ask, like, would you like to use an IUD instead? I think that we really have to counsel, our providers to be more patient focused and oriented. Next slide, please. This is an example of an ESM, and there were a bunch of these that look like this. So it says percent of family planning clinics that have LARCs available. And then another one is number of LARCs utilized among women of reproductive age served in local public health departments. So yes, thank you for that. Long-acting reversible contraceptive is what a LARC means. We know that modern LARCs, such as IUDs, are safe and convenient options. So we should continue to promote them to women who want to access them. But we also have to recognize that the origins of the IUD lie in a eugenic effort to stop reproduction in developing countries. So with that in mind, there is lots of hesitancy about the safety and things like that. So I think promoting an environment where you can talk openly about that is very important. The second point I want to get to is, like, we put so much emphasis on birth control, but I'm wondering how often are general practitioners and family planning providers talking about plans for starting families? You know, because of racism, Black people and people of color experience weathering and allostatic loads that, you know, means that these BIPOC patients carry the weight of more health complications. At what point, like going back to the first point made about like equitable family planning, like would we consider a Black or brown person healthy enough to start a family? I think that that's a really important point as well. So not just thinking about, you know, controlling who gets to give birth and reproduce, but also thinking about like, how can we enable them to achieve their goals and what they see their family, the family they want in the future. So yeah, I am going to pass to Andrea to talk about the next point for the next slide.
Sure. So thank you, Janina. So the fourth question that we just wanted to pose to the group for thought is how can we leverage the state performance measures and the cross-cutting domain to advance this equitable whole person preventive care and wellness. This is a place where we've seen some really interesting and exciting work. So first, you know, Title V programs are using their state performance measures to reduce silos and create some continuous programming to really think about reducing the fragmentation that we see that women experience in the healthcare system and individuals assigned female at birth. We're also seeing that in the cross-cutting domain as a space to tackle systemic oppression. And I'm using the word systemic oppression very intentionally because it actually is a word that we saw show up in some state action plans in the cross-cutting domain, which is exciting and really, really important. So we've seen some good connection here to addressing social determinants of health or undoing racist policies and programs in these specific areas of the block grant annual reports and applications, and in the work just overall that have been supported by Title V. One other place that we've been seeing some promising efforts is where states and jurisdictions have been really intentional in disaggregating their performance data. So national performance measures, state performance measures, and their evidence-based or evidence-informed strategy measures at a minimum race, but by other marginalized identities and the intersections of those marginalized identities to understand the impact of efforts on inequities, including if the strategies they're using, especially those documented in the evidence-based and evidence-informed strategy measures, are having inequitable impacts. So there's an intentionality that we're starting to see among the block grant applications and reports to disaggregate performance data and then to actually report on and assess the changes in performance based on some of this disaggregated data, which is really quite exciting. On the next slide, I just wanted to share a couple examples that we're seeing in block grant applications. So for example, a priority need, improve health equity by addressing community and social conditions and reduce environmental hazards that impact infant and child health outcomes. So the percent of performance measures, a state performance measure aligned with that is the percent of state performance measures that include at least one strategy focused on social determinants of health, at-risk populations, or health disparities. So some of Christina's comments talked about reducing barriers to access, acknowledging social determinants of health have a large role to play in there. So this is an opportunity or an example of leveraging some of that thinking. An additional priority need from another state was improved health equity and reduced maternal, child, and adolescent health disparities, just overarching priority need, with the state performance measure of disaggregated, but percentage of children. So this was focused on children, but this is actually talks about healthcare providers and their families overall. So this could absolutely be adapted for women and for people assigned female at birth, but the percentage of children aged 0 to 17 years who have a healthcare provider who is sensitive to their family's values and customs, or the percentage of new mothers who have ever experienced discrimination while getting any type of health or medical care. The hope is to actually apply and think about how we can gather the same information and measure similar information in the populations that we serve outside of pregnancy, childbirth, and postpartum, but in the context of their families and outside of their families. All right, and on the next slide, I think Janina is going to take us home here with a few last comments, and then we're really excited to hear your ideas.
So today we shared a number of examples of strategies that point to opportunities for deeper exploration of the opportunity that Title V provides to advance equitable preventive healthcare. There's some really promising and exciting examples also that we saw among the state ESMs, and we want to lift those up and celebrate them as well. So on this slide, the ones that we highlighted were like number of women who receive preconception counseling and services during annual reproductive health and preventive visits at family planning clinics. I particularly like this one a lot because I think it attends to, the systemic racism and systems of oppression that we see. This one is percent of reproductive health family planning agency training attendees who report a practice change after completing implicit bias training. And then another priority need that we spotlighted is just supporting and affecting system change by promoting policies, programs, and actions that advance health equity, address social determinants of health, and deconstruct these systems of institutionalized oppression. Next slide, please. To close out, I just want to say that MChip is so excited to be a resource for you in your work maximizing the potential of National Performance Measure #1. You can find our contact information right here. We're also very excited to learn from all of you about the strategies you are exploring, especially now that Title V programs just submitted their Title V block grant applications and annual reports. So please don't hesitate to reach out to any of us.
So I'm going to jump in because I'm really excited about the potential of Title V. I think, as we mentioned, this is Title V programs are national. They have potential for major influence and major innovation. And we really would love to hear from you, either your response to some of those questions or some things that you're doing. But I wondered, Andrea and Al, do you want to check in with Rio? See where her drawing is?
Sounds fun. That'd be great.
Hi, everyone. My name is Rio, and I am your graphic recorder. And perhaps this is a good time to sort of orient you to some of the themes that I've been hearing and what I've been capturing. So you can see my screen. I know it's a little blurry, and you might hear a dog in the background, just as a heads up. But really at the top here is the orientation that we received, where first well, not first, but Andrea gave some context setting about the power of Title V, where there is flexibility. There's not just funding, but also relationships. And the flexibility and variability to fit into and support the cracks in the fragmented system. Then we heard also from Carrie Ann about NPM1, some of the history and the adjustments, and really what I took from that, given the context of this conference, is that it's for women who are thinking about preconception, interconception, post-pregnancy, and also women who are not planning on pregnancy. It's thinking about the whole woman's health. And I also wanted to flag, for those of you who aren't as familiar, one of the invitations that we received was, if you're not familiar with Title V, you can use this time to listen for leverage points and partnership opportunities with your state agencies. And then down at the bottom were some of the things that I was capturing from the AMCHIP team as they invited us to think about these 4 questions around who provides care, and really what does that look like? How can we support and reinvest so that there is a community of providers around women? What does access look like beyond geography? That could be transportation, it could be working in a job where you can take that time to go to an appointment that might run late. If you're doing telehealth, do you have access to the internet? Do you have access to culturally humility, to providers with cultural humility? Next, how can we equitably include family planning in these conversations? And this is around listening to patients and their preferences, enabling, not just controlling, providing a safe space to talk about the history of contraception. And then finally, how can we leverage the SPMs and cross-cutting domains? And really what was coming out here were ways to actually use this to look at systemic oppression, not just look at, but address, and look at the intersectionality that occurs in folks' identities and ways of being in the world, disaggregating data and getting into some of those more specific ways to actually do this. So that is what I have been hearing and capturing, and I will keep adding to this. And I'm excited to listen to participant ideas, questions, conversations that come up. So I will hand it back to Sarah.
Thank you. So something this is making me think about are some systems kinds of work. I'm curious what some of you have seen different states doing that might be, I mean, I'm thinking about the difference we saw with insurance, for example, and thinking about broadband. Are you seeing some states thinking about some like systems or policy approaches to this measure as well by chance?
I can get us started in that question, which you might have to keep deconstructing for us a little bit, Sarah, because it's a good one, but I want to make sure that we're addressing it in the way that you're asking it. I mean, just based on, you know, so AMCHIP was a backbone support organization for one of the infant mortality coin efforts, in particular on social determinants of health. And, you know, and in that space, I think there's a lot of interest. It seems like there's a lot of interest, a lot of excitement from Title V programs and from their extended partners to be thinking about, to not just be thinking about, you know, once she or they get through the door, to be thinking beyond that. So not just through the door, but everything that wraps around what it means for them to be there. And so I'm seeing, we're seeing at AMCHIP, I think a real appreciation and interest in not just social determinants of health or structural determinants of health, but in the policies and practices that undergird those and keep especially racist policies and programs in place. And a desire to disrupt those. I think where it's really interesting is the translation of that interest, of that passion, of that desire, translating that acknowledgement of that accountability and of that responsibility and that power, translating that into specific strategies, that are measurable within the context of their block grant efforts. So that's, I think we're in what's really exciting, and I really can't wait to see what all is written and shared in this year's round of the Title V block grants and annual reports, because I think we're really at the cusp of some really interesting translation efforts in that space. So that's kind of, I know that's kind of a broad response. I don't think, what some of the evidence-based strategy measures and evidence-informed strategy measures that we shared today were based off of the most recent reports. And so I think we're seeing, and I will say too, that they're based off of what we saw in the sort of specific to NPM1, but that doesn't represent necessarily where an individual state is in the other domains. And so I think we're in an interesting opportunity, an interesting place to see the translation of some of the equity foundational thinking that has been happening in maternal and infant health, but to try to actually translate that into preventive well woman visits, preventive care, whole person supported care across the lifespan. So that's kind of I think an overarching observation. I'm curious if that aligns with the work of the preconception coin and that observation or observations from that space. But I'll stop there and give the floor to my colleagues and Carrie Ann, and then Sarah and others for your thoughts on that as well.
Yeah, well, that really, I thought was a great answer. And then I think also thinking a little bit about what Kay Johnson and the other panel mentioned about also payment mechanisms. So there's a whole wealth of things to consider at every single point of kind of the cascade of helping someone be able to access a visit, have that visit count and matter and uplift, and then resources to be able to act on advice that was given. So I think you're right, there's lots of different points and intersects for intervention. I'm looking at the chat, and I wanted to also shout out to Team Utah, because it sounds like you're doing a whole strategic plan about the well woman visit. And so I hope you'll tell us when the plan is done so we can share it, because I think I'm really excited about that. And if there's any elements of that you want to chat, that would be great. We did have a question about how folks are engaging and collaborating with reproductive justice organizations. So that kind of gets to your partnership relationship. Have you seen that happening in any of the states? And that's a great suggestion. Carrie?
I will just say Rhode Island is contracting with Sister Song, I think, they contracted with them during their needs assessment and really provided a lot of insight into their health equity work and maternal mortality work. And so they're going to continue to contract with them to support, improved implementation of their equity efforts through a variety of their programming for women maternal health.
Thanks, Carrie Ann. That's really cool and great to hear, and something it'll be fun to follow up on more. I can just share, I think we're seeing I'd really love to hear Christina and Janina's thoughts on this. So I will just say at a high level, I think we're seeing a real range of partnership with reproductive justice centered organizations and community-rooted organizations that have the trust and the trust to represent Black birthing people, Indigenous birthing people, and people of color. So I think we're seeing a real range and a range in how what is the quality of that partnership, and I think a great variety of definition of what it means to partner as well. So are we talking about a single contracted funded relationship with one organization? Are we talking about uncompensated representation on task forces and other spaces? There's a really wide range, and I think Carrie Ann's starting with a really neat focus on embedding a reproductive justice organization into a foundational aspect of the Title V block grant, which is the needs assessment, is just such a cool, really important layer and level of that. But I will pass it over to Christina or Janina to see if they have anything else that they want to add, especially from their vantage point of facilitating so many really neat collaboratives.
I can quickly add and say that I am in full agreement that it's a variety of levels of engagement. I think you gave a great example of how the levels or the gradient of engagement changes from state to state or from place to place. I think we're really fortunate to see that some states are, doing some engagement of, really inviting RJ organizations and thought leaders to spaces that they are holding to really be partnered in like true and transparent partnership. I think I would also be remiss if I did not say that, it's unfortunate that we are presently in a world where reproductive justice, as well as its concepts and many of the tenets to that the founders of reproductive justice were intentional in including in their framework have been politicized, which impacts, I will say, how or the level of like organizational support that we can sometimes see. I'm trying to be diplomatic. I think we all understand where I'm going though. I think that's unfortunate. It's great though to see that, again, some states are able to kind of navigate that and figure it out. Work through other conveners and other people working to really help support that. And I think that we're really hopeful that we can think through how we as a support, AmChip as a support can kind of think through and talk through how we can provide support, as well as how some of the organizations that we have been working with, how we can continue to, bridge them to our partners who we know have a lot of interest.
Yeah, I want to lift up that because I think you mentioned earlier about it's not just family planning, but it's also helping people that want to start families is really an important part of that reproductive justice continuum, as well as I'm going to say the word abortion just because I think that's what you're trying to say, and that's just an option that many women do access who we are serving. And also wanted to lift up conversations around miscarriage as well and infertility. There's so much loss and suffering that people face that seem like they are also certainly well placed in our expertise as maternal and child health experts as well. So I just wanted to lift that up. Wanted to note from Mch in Utah that they are, for their plan, they're looking at creating a shift in culture. So seeing that routine preventive care is self-care, which I love. It's such a show your love construct. And that you matter. We know that that really is important. And that they're focusing on women, providers, and the system, which I think is also a really exciting approach. Well, I just had one other question, because when Carrie Ann was talking about performance measures, you mentioned the adolescent preventive wellness visit. And I'm wondering, is there more, and of course it's very different approach, but I'm wondering, is there evidence within the adolescent wellness visit that we can bring to women's preventive work, or are there resources, or just kind of curious if you wanted to take a minute or two to just, if there's anything you wanted to share. Do states often do both at the same time? Just curious.
I will say adolescent well visit is a highly, most frequently selected NPM. So the likelihood that, and so is NPM1. So there's going to be many states who've selected both.
And, I'll just add, I think I think there's been a really exciting shift in what it means to partner with, center, and be led by youth in the space of adolescent well visits and beyond, especially in the space of mental health. And there's great collaboratives and work and efforts underway in that space. And in many ways that being led by youth is a really beautiful example or model for the opportunities for healthcare and centering women and people assigned female at birth in their care and in the support that they deserve. So I think there's a challenge sometimes with the domains, a challenge sometimes with how staffing is structured within state health agencies is that there are silos, I'll just say, and it varies by state, but there can be silos in sort of the teams that are working and building capacity in one area and teams that are building and working in building capacity in another area. And so it's not always fluid and seamless how the lessons across the various levels of work are shared, but there are some really cool examples out there and some great work underway. But we have a lot to learn and all the things to be excited about for this youth leadership momentum. And I think this really beautifully follows on to questions that have been asked about partnerships with reproductive justice leaders. What does it mean for Title V to listen, to sit back, and to be led by the priorities of the individuals that this work exists for? So that's what I'll add.
I think also thinking also about how maybe the youth can, like you said, move towards this, because there's also these transitions of care. So I have two young adult children, 21 and 24, and it's confusing about when do I just stop going to my pediatrician because I can't fit in the chairs anymore, and what does that feel like to go to a different provider, and how do I know who to find? And I know we've had people that have also struggled. So I think you're right. Like, this is also how do we look at partnerships and relationships and think, really lean into that life course of a life of really well, high quality and person-centered care. So I wanted to lift that up. So we have just a few minutes left. Oh, yes, go ahead.
Just point out for those who aren't as familiar with Title V, we also have a national performance measure related to improving transition to adult healthcare services as a national performance measure. So again, like, I mean, the connections are there within the guidance to be made. We have adolescent well visit, we have transition to adult healthcare services, not just for children with special healthcare needs, which is normally what it's focused on, but for all adolescents. And then we also have, leading that into adult well women care.
So I have a quick question for the folks that are listening that are not with the Title V organization, but are now very intrigued and might like to partner with them or might have something to offer to them. Might you have suggestions about how kind of someone would know how to connect in their state with their person or this group? Thinking maybe your website.
Sorry, Sarah, was that a question for us or was that a question for the audience? Sorry.
For y'all. I mean, if you have suggestions for them. I was just trying to think about, if they're really excited, like, I want to know about all this. I want to find these people.
I just uploaded the link to the list of state contacts on our TVIS website. So it has all the state Title V MCH directors as well as the directors for children with special healthcare needs. That you can go and contact them.
That's awesome. And I noticed that Jill is on from Oklahoma, and we've had a chance to partner with Jill, and she works with the Title X, the family planning, and y'all mentioned that as well. So again, so many opportunities to be connecting with and partnering with Title V, which is exciting. Well, so we have just a few minutes left. I would like to go and have each one of you have a chance for a final word, thought, charge, wish.
I'll just say, from the DISH perspective, we value the longevity and stability of Title V and how it allows for, and it's structured to allow for that flexibility for a state to respond to their needs that they identify. It's always a source of great innovation because states know that funding is there, that they can try something new. It's a source of stability for states. So we're always learning from you, and it's your needs assessment greatly informed the strategic plan for the Bureau. So as much as these things are identified through the state Title V needs assessments, as well as organizations who want to partner with Title V can have their voice heard too. It's a really unique and additional power of Title V. So there's lots of opportunity.
I think I'll just echo Karianne's statements and also some of the what was shared by my colleagues earlier, that first, MChip is always happy to support connections, especially I'll also say internally, we are really working to center equity in our work. And we really believe that that cannot be done without really transparent and intentional community engagement. And so as we're thinking about, and PM1, like this conversation about well women care, we really believe that communities need to be centered in that conversation as well. And so our ears are open, our inboxes are open, and we really want to continue the conversation of the questions that we posed here today, because exactly as you said, Sarah, earlier, there is a huge space for innovation and for things to be piloted and tried out, and for us to really rethink about how we can do things in a new way, in a creative way, in an innovative way, if we just take that leap and that chance. So we are here and available. We want to continue this conversation. And we really want to, be in partnership with not only communities, but you all who are on this call, our fellow panelists. We really want to continue this work with you all. So thank you again for the invitation.
And then I'll just add in closing that I want to express gratitude for Christina for cracking the door open for our conversation about abortion, and for Sarah for kicking that door open a little bit, because I felt a little bit of a pressure valve release in that. And I want to just say very much that AMChip, in our role as a member service organization with the state and territory health agencies, are really eager to hear confidentially, at sidebar, however we best can, what current attacks on systems of care for individuals needing abortions, what that means for you and your work, acknowledging that this is creating a landscape, especially that politicizes and fragments care further. So, and creating some really interesting things that we see of movements across different systems and across state lines, and it has ripple effects, extensive ripple effects. So just wanted to offer that in our role as a member service organization, that we're here to listen, and here to listen not just to our members, but to the broader network of folks and colleagues about what is good public health, and how we can be best of service in this space. So wanted to lift that up and express gratitude again for opening that space, Christina and Sarah.
I want to thank all of you for your time and energy and this really awesome conversation. And I want to lift up all of the folks working in this space. You all are innovators. This is new. We are shifting the paradigm, how to go from maternal to flipping it upside down. And so I just want to uplift that work and offer gratitude for your time. And I'm going to pass the mic back to our awesome MC.
Thank you, Sarah. And thank you to our friends and fearless leaders from AMChip. Thank you specifically for not only giving us an understanding of what Title V has been, what it is, and where it can go, right? And really doing the right thing here. So I am so excited that we were able to hear from your insights and calls to action. And now we'll take a quick break, and then please come back at 1:30 for our keynote session. You do not want to miss this fabulous content. Oh my goodness. The period doc, her name is Dr. Chambers, is a powerhouse of an OBGYN that is leading the way on patient advocacy, patient engagement, and supporting learning in a way that is relevant to us. If you haven't seen her video clips and various health topics, go to her website or Instagram, find her, follow her, love her. Oh my goodness, she has a repertoire of masterpieces. You can look her up at www.theperioddoctor.com, and you're going to hear about all of her brilliance again at 1:30. We'll see you back here in a little bit.
Thanks, everyone. Thanks, y'all. Hello, greetings all. I see that people are starting to sign back on for the keynote this afternoon. Before we get started listening to the period Dr. Chera's Chambers, I wanted to go ahead and show some of the videos that she posts on her Instagram. So these are video reels that she's posted. Some are provider focused, some are her talking to patients, just to get a little taste of the type of content that she creates.
Health outcomes based on modifiable risk factors. Of adverse health outcomes based on modifiable risk factors. It is used to optimize health and provide individualized education. Any patient with reproductive potential is a candidate for pre-pregnancy counseling. This is regardless of relationship status, gender identity, or sexual orientation. A preconception visit is designed. Hi there, I'm calling to schedule a new patient appointment. I'd like to schedule with a provider that's a Black female. Can you help me with that? I'd like to schedule with a female provider. Can you help me with that? I'd like to schedule with a provider that's a woman of color. Can you help me with that? I'd like to schedule with a provider that's bilingual. Can you help me with that? I'd like to schedule with a provider that's dedicated to caring for trans or non-binary youth. Can you help me with that? Hi there, I'm calling to schedule a new patient. Happy Valentine's Day, lovers. Let's talk about Plan B. Plan B is a form of emergency contraception that utilizes a high dose of progesterone to hopefully prevent ovulation. It's important to use Plan B as soon as you have contraceptive failure. That can mean a missed pill or slippage or breakage of a condom. Plan B is not meant to disrupt a pregnancy that's already forming, and it's not an abortion pill. While Plan B may cause changes to your menstrual cycle and temporary irregular bleeding, it's one of our best options to preventing unplanned pregnancy after contraception failure. Happy Valentine's Day. I advocate for myself as a physician when I go to see my doctor. Number one, I try to narrow down my complaints. I pick 1 to 2 things that must be addressed during that visit. Number 2, I always bring something to write with. There's a lot that's said during doctor's visits, so you want to capture it all. Number 3, I always ask questions, especially when I'm starting a new treatment plan. I often ask questions about the risks, the benefits, and the alternatives. Here are 3. Here are a few ways to ask for a second opinion. You know, I'm not quite comfortable with that recommendation. Do you have someone else that I could talk to walk through this? I'm not exactly ready to commit to this treatment plan. Is there a colleague of yours that I could review this treatment plan with? I'm not understanding this diagnosis or treatment plan. Is there someone else that I could talk to that's also in this specialty that could review my records and give me their opinion? Here are a few ways to
Welcome, everyone. So hopefully you were able to join us for the break. We previewed some of that great content from Dr. Chera's Chambers, the period doctor.
I wanted to intentionally show you her Instagram feed just so you could see all of the different types of videos that she's created. They all have different audiences, and I'm sure she'll touch on that. Some are for patients, they're patient facing. Some videos are for the parents of patients, and they address privacy and having a well visit with a parent or with a significant other. She talks about her own, tips from being a gynecologist and about being a health provider. Hello, good to see you.
Hey there.
Hi, well, we were just getting started and saying our welcome. We just previewed a few of your videos. I showcased the Instagram Reels page just to get a taste of the different types of videos and audiences that you speak to, from the patients themselves, other providers, parents, significant others, health professionals. There's a lot of call to actions in your videos as well. So just to get a taste of the different types of content that speak to different audiences, that can really help to raise these conversations and help patients advocate for themselves.
Thank you so
So
much.
with that, I know that Sarah, Anna, you are ready to get going with this next session. I am so excited. I'll be live tweeting, we'll be putting on Instagram. So I'm going to go ahead and turn it to you.
Wonderful, thank you. And welcome back, everyone. It's happening. Oh my goodness. Finally, we're about to hear from Dr. Chambers during our keynote session today titled Transforming Patient Care and Engagement Using Social Media. It is really my utmost honor to introduce her, because not only does she know what she's talking about, but it's so relevant to us. She's a medical doctor specializing in obstetrics and gynecology, who is #changing the cycle. She brilliantly leverages the power of social media for the greater social good. She's innovative, resourceful, truth-telling, and demystifying health and healthcare one post at a time. She'll be speaking with us today about ways that health professionals can enhance their patient experience, as well as sharing information and resources that are person and community centered. Dr. Chambers believes that folks should have access to information that allows them to understand their bodies, protect their bodies, plan and manage their periods and/or pregnancies, and do all of this free of judgment, coercion, and marginalization. It is time to change the cycle and all the cycles, and Dr. Chambers is leading the way. I pass the mic to you.
Thank you so much, Anna, for that amazing introduction. Oh my goodness, I cannot tell you how excited I am to speak with you all today. So I'm going to pull up my presentation on my little share screen, and I famously go to the wrong slide to start with. I don't know why I do that. So I'm going to see if I can actually get to the beginning of my slides here. Let me just see here. My apologies. And thank you also to Suzanne for kind of showing some of my posts. I love being able to reach folks on social media, and I'm just going to kind of talk with you in the general sense about social media for the clinician, how to use social media to achieve transformative patient engagement. And I don't just use that in some lofty kind of catch-all, tantalizing title. I truly believe it and I live it. And so that's why I'm super excited to share with you my journey, kind of the background of social media, because a lot of folks, especially in kind of the healthcare field, are like, what is this social media thing about? Like, what are we even doing? Why do we feel like this is relevant? Why are we here? And so I try desperately to kind of talk about that and why the relevance is actually very real. So I'll talk about a little bit about me. So my background is that I went to Spelman College. I attended medical school at UAB, which is in Birmingham, Alabama. I'm from Alabama originally. I went to Greenville Health System for my OBGYN residency. And then after that, I attended fellowship in Houston, Texas at Baylor College of Medicine, where I just love my training, had the privilege of just kind of refining my skills as it relates to my subspecialty, which I enjoy so very much. And then in 2019, and that's really why I'm talking to you guys today, I founded the Period Doctor platform. And so that was super fun. And really the basis of my discussion with you today. And I'm just going to walk through what that journey has looked like and kind of how it came to be. So to start, my objectives, I want to review the evolution of social media and the difference between the available platforms. I want to discuss the literature that supports that there's some intersection of healthcare and social media. Of course, I'll share my personal social media story, and then I'm going to propose some potential ways for clinicians to start making your own mark on social media. So, as Charles Darwin says, it is not the strongest or the most intelligent who will survive, but those who can best manage change. So let's get into that. The evolution of social media. Ultimately, how do we get here? What even got us to this place in which there is this discussion about how we can incorporate social media into medical practice? What even is this? So in 1991, the World Wide Web was created. And that really opened the opportunity to use the internet to communicate via text. And so in 96, we had Google, which is such a wild concept because now we've just seamlessly incorporated Googling and into our everyday lingo. And it's like we can't even remember a time in which we didn't have the opportunity to just Google something. If you don't understand it, you Google it. If you need more information, you Google it. Google's a part of research and presentations and everything that we do on a daily basis. And that started in 1996. Then we had Blogger in 1999, where folks are actually just kind of blogging in long form to communicate their ideas or opinions or lifestyles to others. Wikipedia started in 2001, 2003, we got our MySpace and our Facebooks, with Facebook really being kind of that leader of like the social media platforms. 2005, we got YouTube. 2006, Twitter jumped on the scene. 2010, Instagram and Pinterest. Snapchat in 2011, and then TikTok, which is all the rave. And 2012, it really got popularized kind of later in 2014 to 2016 in the United States. So there was actually a research study. The Pew Research Center looks into kind of the use of social media in the United States. And it showed that in 2019, 72% of American adults used some form of social media. In 2005, the year after Facebook went live, that number was just 5%. And so that speaks to the kind of exponential growth that we have seen over the last decade, 1 to 2 decades, as it relates to social media and the use of social media and just what it means in our daily lives. And it's everywhere. Like even the majority of our news stories are constantly covering social media, anti-troll tools on Twitter, just how this affects our dopamine kind of receptors and turning us into dopamine addicts. And then social media kind of increasing child safety. It's everywhere. It is a part of our daily lives. And quite frankly, it is not going anywhere. And so that's kind of how we got to where we are today. So today, social media is used by more than 5 billion mobile device users worldwide. And if you know anything about the global population, it's about at 7.9 billion. So a lot of folks are using social media. If you want to reach people, that is where you need to be. So a little bit more about kind of social media and how it's in the United States. And I believe this was actually from an article in 2020 and kind of looked at research back in 2018 and beyond. So the numbers are a little bit outdated, but ultimately it still speaks to the majority of folks utilizing social media platforms. And this is US adults, about 72% using some sort of social media, a little bit more, like 73% using YouTube, because a lot of folks use YouTube that may never use a Twitter or an Instagram, but it's a great search engine for videos. 69% using Facebook, and then 75% using Instagram, Snapchat, all of those things. I mean, the vast majority of folks are using one of these platforms, if not multiple. And then just the increase of digital advertising. And that's kind of where you can see where influence and reach is. If the money is there, if that's where people are trying to reach folks when it comes to advertising, this is where the people are. The money and the advertising always goes where the people are. And so this is from 2018, but online revenue was $107.5 billion from an online market standpoint. The TV revenue was behind that at 70.9 billion. And then radio and newspaper magazine just kind of were left in the dust because they're really kind of just, something of the past. They're becoming not entirely obsolete, but certainly being replaced largely by the social media online kind of presence. So let's talk about the different platforms, because I know that there could be some level of confusion there. And quite frankly, there is some overlap in the platforms. And so if you don't get it all today and you don't fully understand it, that's perfectly fine. You really just need to find a platform that works best for you. So to start, we've got our Facebook, right? It's really the prototype of platforms. It was the platform that did it right, had crazy amounts of growth, and really set the stage for what social media looks like today. It's an estimated 1.7 billion users worldwide. And as I mentioned from the other article, about 69% of US adults use Facebook. The largest represented age group for Facebook is actually between the 30 to 49-year-old demographic. And that's just relative to the other age groups. So who's actually on Facebook? YouTube, again, is the largest video search engine in the world with over 2 billion users worldwide. 81% of US adults have used YouTube or use YouTube in like a monthly basis. And the largest represented age group in here is 18 to 29. You're really going to see that 18 to 29 being prevalent in the majority of these platform demographics. And that's just because that's the group that uses social media. That's the group that kind of grew up with cell phones in hand and tablets and all of those things. And so social media is a part of their daily lives and more incorporated than maybe some of our older adults in the 30 to 40 age group. Twitter was considered to be like a micro blogging site. And so the idea was not so much long form blogging, but that you would type kind of character limited phrases and thoughts and kind of engage in discussion. It's not really meant to be like a photo sharing, kind of video sharing kind of site. So when it goes to like Facebook, for example, that was where they had albums and, photos and videos were a part of it. Certainly YouTube, definitely video focused. No one's reading some long paragraph on YouTube, but Twitter was meant to be a place where, thought leaders and people who have a lot to say don't necessarily want to post a selfie every day. That's where they kind of were found. And that's kind of the community for those types of things. And certainly there's a lot of legitimacy with Twitter over the last, several years where a lot of official kind of news literature comes from Twitter. So anyway, 23% of US adults use Twitter with the largest represented age group, again, still that 18 to 29 age group. Instagram was founded as a photo sharing site. That was truly the intention. Instagram, that was the whole kind of idea behind it. Of course, it has changed. We've got these captions that can be very long. I'm one of those people that loves a long caption. I still need to kind of erase things to fit into the caption limit. And certainly we have switched over to video sharing and things like that. So more than 1 billion users worldwide and 40% of US adults do use Instagram. Again, the largest represented age group is still that 18 to 29 age group. Then we got our friend TikTok, which is like the new kid on the block, certainly a force and definitely a force from a marketing standpoint. But it was founded as a short form video sharing site. There are more than 800 million users worldwide. 21% of US adults are on TikTok. The largest represented age group, now this is from the Pew Research Center rather, and they really looked at adults only. So that says the largest represented age group is 18 to 29. But if you look at a larger demographic that includes, kids that are under 18 as well, you really see that a fourth of the users on TikTok are between the ages of 10 and 19. So that's really where you want to go if you want to reach a much younger age group. If you're trying to reach the teens and tweens directly, that can be, your preferred platform because that's where they are. And so really understanding the platforms, and these are just kind of, overviews of the platforms, but understanding them and really kind of tinkering with them and seeing what works best for you and what you're trying to convey is super, super important. So let's talk about the intersection of social media and healthcare. So the thing is with social media, you can disseminate information widely and quickly. And for that reason, we can use it. Health institutions can use it to post health information and share that information with the greater public. And so it just kind of makes sense. And that was really my thought process when I was getting involved in social media. It's like, hey, I can reach a ton of people here. And then you look at other things. So as Suzanne mentioned, social media is used by a number of folks, and I use it in a number of ways to reach my patients, but to reach their parents, to reach their teachers, to reach their fathers, siblings, partners, to reach other care providers. And so social media is being used by a ton of folks in a number of ways. So social media is used by 80% of cancer patients to connect with their peers. There are communities in social media that create support groups that were once relegated to just meeting somewhere in a church basement somewhere. So if you couldn't make it to that support group, you couldn't get there. And so social media has allowed there to be certain sectors of community, and community is needed within the patient population as well, from a patient to patient standpoint. And then for healthcare organizations, more than 80% of US health departments have social media accounts. That's huge. And then even among health professionals, there's a lot of health professionals on social media. I have no idea why they selected radiologists, but they said 65% of radiologists across the United States and Europe use social media for various health related reasons. And so there is relevancy an application within the social media land to kind of healthcare and the healthcare sector. There are other advantages of using social media over other sorts of media outlets. And so social media is seen as, fast, as I mentioned. It is the fastest among the available channels to share alerts and updates, especially about disease outbreaks. And so a lot of this specific article that I referenced for this was referencing social media in the age of the pandemic, which is when social media really kind of just came up to the front stage and showed us how powerful it really is in good and bad ways. So it also allows us to leverage various media forms. So I can integrate a hyperlink into my post that then directs folks to, youngwomenshealth.org or Planned Parenthood or any other kind of reputable online resource that I want my patients to understand is a good resource for them. So through my page, I can then kind of guide them, to another resource, which is really cool too. And then, of course, we can communicate with other stakeholders. I can communicate with other physicians, some other healthcare providers, nurses, medical students, other people in training, and even news outlets, to really communicate regarding the status of things. And, of course, they're referencing disease outbreaks, certainly, and that's been relevant as of late. But there's a lot of official information and sources that have come from social media that they can then be incorporated by journalists in a very timely manner, very, very quickly. I've had multiple tweets and posts that are incorporated into magazine articles and news articles because that's where you get your information. That's where you understand what's going on, how people feel, and that's where authorities on these matters are located. And then, of course, there is the glorious and never-ending, heartbreaking, tiring war against misinformation. And of course, with COVID-19 and the pandemic, we really saw this kind of come to the forefront. There was an increase of misinformation during the COVID pandemic, so much so that researchers were suggesting that health institutions actually do something about it. So what they wanted was that health institutions and providers increase efforts to monitor and enforce fact-checking of these crazy and dubious kind of posts, to promote strategic and timely refutation of this misinformation. So I want to refute this as soon as possible before a bunch of people see it and it becomes a bigger deal. And that's certainly something that a lot of my colleagues and even myself kind of feel an obligation, a mandate to be on the front lines, kind of combating this misinformation, because anyone with an account can post something like, oh, this concoction helps with this. And then you've got people, getting sick or dying even from the actions and results of incorporating and getting access to misinformation. We are also called to share personal experiences in social media. And so one of the things that I did, not that there's anyone specifically calling me to do this, but it's just a general consensus that we share these things, especially with vaccine hesitancy, just posting that I was vaccinated and why, and just leading by example in a sense. And of course, redirecting users that are asking these health related questions to reliable information sources. So the CDC says this, the public health kind of websites and schools say this. And so I think it's a super relevant thing, and it's just very timely. There's a need for social media engagement from the healthcare sector. So I hope that was, that was meant to be a little bit of a background. I think I may have spent a little bit longer there than I intended to, but I do want to get to my story and just how I became involved in social media to the degree that I am. And so this picture means a lot to me because I think it kind of captures a lot that can't really be seen. So when I first started my social media account, it was in the summer of my fellowship. I was just between my first and second years of fellowship. And so when it comes to medical training, there's 4 years, of course, of medical school, 4 years of residency, OBGYN residency. And so I was between my first year of fellowship, which was right after my residency, and my second year. And so I was, for lack of a better term, just tired. I mean, really kind of just tired and just looking ahead to a whole nother year of training before I could be real, before I could be a real authority and be out here, participating and affecting change in the way that I wanted to. And in my fellowship, because I was doing pediatric and adolescent gynecology in a dedicated sense for the first time, I really found the degree of misinformation and poor health literacy to be astonishing. I would have just general conversations about periods, just what a period is, the appropriate length and what is occurring in your body when ovulation happens, and things that I just think are fun and I like explaining. And I would find that a patient and their mother, or a patient and their grandmother, guardian, father would just be like, what? No one has ever explained this to me before. Oh my God. I mean, just the shock of just a minor, 2-3 minute discussion on basic physiology, basic anatomy was received with such appreciation. And I just remember just like, why don't we talk about this more? Why isn't there better education? Why don't we do this more often? And there are a myriad of reasons why that's the case. With schools not necessarily prioritizing sexual health or not prioritizing accurate, like medically accurate sexual health, and just the taboo around talking about, the female body or talking about sexual health and reproductive health. There were so many reasons why this was happening again and again, every time I encountered a patient and guardian pair. And at first it was kind of cute because it made me feel very special. But after that, I was just very frustrated because we were having the same conversations and everyone had the same questions. And I felt like I wasn't doing enough. And so I started to think about it and I said, if I scheduled a 30-minute new patient appointment every day for the rest of my life, I would never reach as many people as I could possibly reach on like Instagram. Okay, and this is back in 2019, so it was pre-pandemic. I didn't know the world was going to shut down and everything would be remote. I didn't have the ability to predict that, but I knew that if I wanted to meaningfully reach people where they were, social media would be the best bet. And I felt that way because, even when I would see my patients in our clinics, and so we had pediatric and adolescent gynecology, the access was there, but you had to get to us. You still had to have a parent or guardian take off work and get to us, have childcare for your other younger siblings and get to us. And so that's still a barrier. It is not meeting people where they truly are. And so I noticed in kind of my patient demographic, I wasn't seeing a lot of minority patients sometimes, or they would have trouble coming back to their visits. And so I said, these patients often still have access to some level of social media, be it on a phone, an iPad, a computer, a friend's phone, somewhere. We can reach them where they are if we can get on social media. It doesn't require, payment, subscription, it can be very anonymous. No one has to actually even follow. They don't even have to comment. They can just watch and learn. And so that was kind of my thought process on entering the social media space. But I must say, when I told some of my co-fellows and other people, they were just, it was a lot of hesitation and doubt and just like, why? Why would you add that to your plate? Why would you think that social media and healthcare kind of go together? Who does that? And I just felt in my heart that this was an important step, that this was going to allow me to get my message, which was a message of health education in a way that people can understand it, that was free of judgment, that was able to be flexible and be modified according to levels of health literacy, that could approach and address with sensitivity, cultural kind of factors. All of those things I wanted to do. And I was just in a place where my training was such that it was just a whole year from graduation and I wanted to start making an impact. So that was my backstory. So I came up with the period doctor. And my thought process was simply, that's what I wanted to focus on. I wanted to distinguish myself from other OBGYNs in that I'm not focusing on pregnancy, menopause, fertility, conception, any of those things that are really popularized and somewhat saturated in the social media sector because there's a lot of money-making potential. I really wanted to focus on the adolescent and the menstruator, the person that is just trying to manage their periods and figure out their bodies and live their best life. And so I said, I want to be called the period doctor. So I'm going to go with that. People will understand what I do right up front. There's no discussion, no confusion. And it's a gender neutral name, which was super important to me. I didn't want to just be Dr. Shars. And I love my name, but my name was not the easiest to pronounce. And so, the period doctor is easy. It's recognizable. I spoke with a friend of mine who's incredibly talented and creative. And I was like, I need a logo. I need something to make this real and tangible. Just because if you type out the period doctor, it doesn't have the same kind of approach. And so we came up with this cute logo using a uterus as the T in doctor, which of course I love. Anything that has a uterus or an ovary or anything, I'm like, oh, I love this so much. And so that was my logo. So I felt really grounded and really cool having a logo. I posted to my personal Instagram page, hey guys, I'm launching something. It's a passion project. I'm so excited. And I chose a launch date. I said July 1st, 2019 is go time. And that was part of kind of just, moving forward and committing to a date and putting it out there so that there was some accountability. And so I said, who am I? Well, an OBGYN with fellowship training in pediatric and adolescent gynecology. That's who I am. But I wanted to be more specific. So I said, let me come up with a mission. What is my goal here? What is it that I wish to contribute? And so my mission, and this was my initial mission, I've gotten a little bit better as far as kind of gender neutral language. And so my updated mission is more to educate people, teens, on topics related to their reproductive health in an effort to promote greater self-awareness in everyday life. So I just want them to be more self-aware, everyday life, moving throughout the day, going to work, going to, basketball practice, going to a track meet, just being able to navigate spaces with authority and with understanding, having greater self-esteem, especially in relational encounters with partners, intimate partners, with peers, understanding that their body is appropriate or what's normal, that there isn't something abnormal about, different breast sizes or breast asymmetry or labial asymmetry, or all of these things that we know as doctors are okay in normal variants, but we don't put out into the world to reaffirm this for our teenagers who are going through body kind of and self-esteem issues. And then greater self-advocacy. This is super important to me because I don't want a recluse teen that feels like they have no voice when it comes to interactions with medical providers. I want desperately to promote great self-advocacy because I feel like that's when the doctor-patient relationship is optimized. But that wasn't enough. I wanted to do a little bit more. So I said, let me think about my bias. Like, what is my bias? Who am I? It's great to say, I just want to educate people, but I feel so strongly about this that I need to kind of clarify this picture so that you really understand who I am. And my true bias, as in this colors everything that I do, is that women and menstruators, should have access to information that allows them to understand their bodies, protect their bodies, plan or manage their periods or pregnancies, and do it all, free of judgment, coercion, and marginalization. Because that's what I care about greatly, that you are empowered, and so thereby liberated to manage your bodies, your periods, your pregnancies, all of those things, so that you can achieve all that you have to offer in this world. And do so, free of judgment, because it's one thing to offer something and still judge. It's one thing to kind of, manipulate and coerce someone into doing something. It's one thing to then marginalize a population, say, yeah, it's there, but you got to go through hell and high water to get to it. And so that's what my bias was. So I really wanted to include that. And then I came up with, a kind of catchphrase / hashtag that I use, hashtag change the cycle, or it's time to change the cycle. Obviously, that's kind of play on words, changing the cycle of generational misconception, but also changing the cycle, the period cycle. And so that was my framework, kind of my outline that I started with. And this was well before I posted much of anything. It was just to ground me so that I knew where I was going. So I identified some gaps that I wanted to fill. And I'd like to just pause. These pictures that I'm showing you, the very first one that I showed sitting at a computer, and this one, I was in my apartment building, in like the common area of my apartment building in Houston, Texas. And I had a photo shoot because I said, well, if I'm going to be using Instagram, I have to post pictures. And so I bought this white coat off of a social media site, off of a website called Metalita, which I love and still actually work as an ambassador for occasionally. And I needed a good white coat that I could film in to show that I'm a doctor, so that there was some visual representation, and visual marketing, so that that I'm a physician. This is what I'm doing, and not just some girl in a pink dress necessarily. I mean, I still do things in a pink dress, but just for the purposes of getting that brand across and brand recognition, I needed a white coat. Threw in a stethoscope and had a photo shoot. So all of these pictures are all from my very first photo shoot. I had no idea what I was doing. I had never posted anything. I just knew that I probably needed some pictures to be able to post. And I looked insane as a fellow that was busy and running around. So I might as well get dressed up and take some pictures on a weekend. So that's all of the background there. So gaps I wanted to fill. I wanted there to be accurate and accessible adolescent gynecology, as I mentioned. Although we had adolescent gynecologists, in Houston, Texas, in this area, we went to some community areas. Even getting to that office, getting to that clinic, even learning about that clinic was something that only occurred when people overcame multiple barriers. Barriers as it relates to transportation and parent willingness to bring them in, and, childcare services for other siblings, all of those things. So I was very aware of that, and I wanted to reach people where they were. I wanted there to be minority representation. It is not lost on me that I'm a young Black female doctor. There's only 2% of Black women that are physicians. And so I still get messages today from people that say, the fact that I even see you, it's just wild. I didn't know people like this existed. I didn't know you existed. It's so important to have this representation. I've had parents show their daughters my videos and daughters being like, well, play it again. Is she a doctor? I've never seen a Black doctor. And so that seems kind of odd, but it's reality. People live in a number of areas where there's significant segregation and differences in socioeconomic backgrounds, and people don't always get access to seeing that certain things and certain roles and certain opportunities are possible for folks that look like them. So that is very important. Likewise, just encouraging underrepresented, and I don't even like the term underrepresented, systemically excluded or exclude, medical students and residents who are struggling through training. Training is hard. There's so many steps and times and places where you feel like you can't make it. I mean, if there's a 10-year time period from start to finish, it's going to get tough. And so just encouraging them. I've been there, tough and concerning and challenging things happened during my training. There were days where I felt inadequate, all of those things to encourage trainees so that we do get to the other side, so that our physician population does increase in diversity, so that we are better suited to care for the patients that we have in front of us. And then increasing exposure and awareness of pediatric and adolescent gynecology in general. There's still people that I see in my clinic today, they're like, I had no idea this existed. And a lot of folks didn't. And that was really frustrating even in my training, because we had such a strong presence in Texas that people just still didn't know that this subspecialty existed. And I realize and recognize, it's a rare subspecialty, but that's why I want folks to know about it. And that's another great thing. If you're trying to let people know, there's pediatric endocrinology. There are doctors who can specifically speak to kids about, their metabolism, their metabolic syndrome, their insulin resistance, decreasing risk of diabetes, or intervening before they become diabetic. All of these things need to be things that people know, so they know who to ask for, what referral to ask for, and that in turn improves access. And then just showing the humanity in medicine. I am a human being. I have a sense of humor. I like to wear pink. I can be feminine and fun. I can be very proud of my curly hair. I can wear my straight hair. I can, stand up for women's rights. I can fangirl for Beyonce and still be an incredible physician. And that is super important. And taking it out of this crazy faraway ivory tower of people that don't care about the general population and saying, not only do I care about you, I am you. I am a patient too. I've been on the other side of medical racism. I've been on the other side of sexism, and connecting with our patients to show that we are real, that we are human, that there is compassion on the other side of healthcare. I think that's super important. So just a quick order of events, and I think I'm just taking way too long, but I'm almost done. I initially started by securing my handles for Instagram and Twitter, securing the URL, theperiodoctor.com. I applied for trademark of the Period Doctor, reviewed my institution's social media policy. One of them was that I couldn't have the white coat or an emblem or a logo of Baylor College of Medicine, which is why I had to purchase my, just standard blank white coat so as to not, go against my institution's social media policy. So that's super important. Almost every institution has a social media policy, and that's just to cover them. They have to protect their brand, protect themselves. Social media is a slippery slope, and so they want to be very careful. So review that first. Then I scheduled that photo shoot that I mentioned, downloaded an editing app, and I'll talk more about apps, and then I posted my first Instagram post. All of those things occurred before I posted my first Instagram post. This is my first Instagram post. It's from July 1st, 2019. And I just said, I'm excited to get started with the important work of discussing topics related to women's health. Check out my YouTube and all these things. My YouTube still hasn't been fully launched because managing multiple platforms is hard. And then join me on this journey as we change the cycle. These were my first posts. I was just using an editing app to kind of create some stuff, and it sometimes worked. A public exam is not the same as a pap smear. It was hugely popular. Asking for a friend Fridays, I talked about things like UTIs and things that people weren't super comfortable talking about. Vaginal steaming was something that just kind of came up. And so it's a give and take when it comes to content production, but it still needs to be promoting the brand that you are committing yourself to. Then I kind of shifted a little bit, had another photo shoot, and had some things where we talked about just kind of parents and why, it's important to have that private conversation. Parents, it's time for you to, check in with your period or your daughter if they've had a a period in the first 1 to 3 years, because it's not true that anything goes. You can quick start your birth control pills, combating the idea that periods are natural. So you don't need to mess with them. Yeah, so are natural disasters. And so these are all addressed in touching on different topics and different audiences. And then other key team members, a technology person. I had a person design my website, and I always have someone kind of edit some of my ideas. Most of my posts I do edit myself because I don't know, I don't have the time or so to teach someone exactly what I want my brand to be. Content, I need a photographer, videographer at different times. Hair and makeup, I typically do my own because I want to save money and I'm kind of a budgeter. But having someone style me, I've had a stylist. And having legal, having someone review contracts and give me some stock responses like, I'm a medical doctor, but I'm not your medical doctor. I cannot respond to this. I cannot give personal medical advice. I wish you the very best. And I, recommend you speak to your doctor about this. And then my reviewers, my little sister is a professional content consumer. And so she works as the perfect focus group / test audience. So she doesn't understand it. If I'm using too much medical lingo, she'll let me know and I can change it. And then my posts kind of shifted to things that can be shareable. They can just be text posts, things that, speak to fathers. And that was around Father's Day. And then of course the videos that Suzanne posted more recently, just because, desires on social media do change. And so my content has changed. And so, I was offered my first paid speaking event in like October. I launched my website. I created my LLC. I reached 50,000 followers, and then I became Instagram verified, which just means they put this little blue check by you to say that you're a real person, which is kind of cute, and it definitely improves visibility and kind of makes you a little bit more official. So advice for clinicians, when you're starting, identify your message and mission. Find a mentor or model for inspiration, select the best platform for you, and trial ideas with family and friends. And then once you do that, refine your content, never stop learning. There's apps like Canva. Canva is very popular. Over, which is what I use. InShot and Mojo are great for videos. Canva and Over are great for kind of photos and other content, post story content. All of these are great apps to consider if you're trying to have a social media presence and you want to have some sort of aesthetic kind of appeal. Social media isn't just a trend, it's a tool. And just like any tool, it has to be used wisely. One of the things I kind of caution people is that social media never sleeps and it never deletes. So you need to be mindful of the time you spend on content and engagement, because you can burn yourself out, and be thoughtful of your approach so you don't say crazy things. So when you're posting something, make sure it's relevant, make sure it's relatable, and it doesn't just appeal to you, and make sure you're being respectful. In this time of medical misinformation and truly fractured trust with medical providers, the government, and everything related to kind of medicine and disease management, social media is key. So I believe with proper use, it can truly transform patient engagement and help strengthen the connection between patients and providers. These are my references. This is how you can get in contact with me. And I know we don't really have a lot of time for questions in this time. I think I kind of sped through some things, but I can kind of speak to a few more points if we do have more time. Do we have more time?
Please do. We've gotten a lot in the chat of thank you. This is great info. Well, is this recorded? Can we share this? And then a specific one we have: how do you find the time to maintain your social media presence while also providing clinical services?
Yeah, so I mean, it's all about balance. And I think I love that question so much because it has changed. When I was in fellowship, it was very hard. And so I actually posted most of my posts while I was riding the train. There was a light rail that I took from my apartment to the Texas Medical Center. It was about a 15-minute ride, and I posted most of my posts on that train ride. I was luckily studying for my oral boards. And so I was studying in topic related things. And so I'd say, this is a great topic. I'm just going to post about this. And so the idea was to practice understanding that information and getting the most up-to-date information, and then kind of reframing it in a way that can be digestible by the general population. And so I did that on the train on the way to school. But as I began to be a little bit more engaging and have more photos and videos, that became a little bit more challenging. So I kind of do stock filming all of those videos that Suzanne showed about preconception visits and Black maternal mortality. I filmed that all in one day, y'all. And I was, just in my home with a good ring light. And I say, I'm going to carve out 4 hours this day and just knock out some content, and I'll edit it later and post it, later on. And there are times in which my life is busy. I just bought a house. I'm running around like a crazy person. I won't post for a week or two, and that's okay. I think, there's a lot of unwritten rules in social media where you have to be present all the time and you can't miss anything. You can't be too late and you can't not respond to a comment. And that's just not feasible. I am not a full-time content creator. I'm a physician. I'm very proud of that. And my patients come first. I'm happy to be able to kind of have an extension of medical education and just kind of giving of myself and sharing and engaging on social media. But that is not my top priority. My top priority are the patients that I saw this morning. So I plan to have a full clinic day today, as I did from a morning standpoint, and then switching over to speak with an audience like this. And so it's very thoughtful planning. I'm very picky with my schedule, and I don't have a publicist or anyone else that does my social media planning or engagement because my schedule is so specific. And when I need a break, I take a break. I also try to be thoughtful about the events that I do accept. I've been looking forward to this event for over a month because Suzanne was so thoughtful and reached out very early on, and kind of lining those things up so that I have plenty of time to prepare and work my schedule and block things appropriately, make sure I don't have surgeries. That is how I manage it. And I manage it because it's important to me. It is my heart, it is my passion. And when you're doing something that you really care about, you find a way to make it work.
Thank you. Do you have any, this is a question that I have. Do you have any patients that follow you on social media and that do they have questions about, do they pull up your videos and ask questions about something you said? Does that spark questions that you've noticed in the waiting room or in the visit? Visit?
No, I certainly have. So I've had some patients that walk in and maybe the patient isn't quite as excited, but the mom might be like, oh my gosh, I follow you on Instagram, and so I knew my daughter had to come. The daughter's like, oh my gosh. Or I've also had patients that they'll ask me a question and I will have explained it so much better in my social media post, or I'm like rushing or something. And I'm like, hey, while you're changing and while I have to, do a procedure next door, watch this video. And I did that like with my tampon insertion video. Watch this video and let me know what you think. And then we'll practice inserting a tampon when you come back. And that's one of the things that I just do for my patients because no one teaches them. If their mom didn't use a tampon, they don't know how to. And so they'll ask me, they're like, I would love to learn how to use a tampon. I had a patient do that and she did a perfect job. She placed it perfectly her first try. And we were like celebrating, in the room, like, yes. But watching the video, because I had my little vulva puppet and I had all the areas kind of highlighted appropriately, was appropriate. And so I can incorporate that into certainly my clinical life too.
Thank you for sharing. Go ahead.
Any other questions?
Yeah. Another question in the chat. How has what you were offering on social media impacted your care encounters? Meaning, does providing this basic info give you more time during your clinic to cover more specific content?
Oh, Sarah, such a great question. So that is my hope. That is still my biggest hope. And there are times in which people who have followed me, they have gotten it down. All of these things I'm talking about, the basic, they've got it because they've watched my videos. And so in certain encounters, yes, but I still haven't reached everyone. And so I haven't seen a great, decrease like, oh, I can get into the nitty gritty because you've gotten that basic foundation from my social media. I think we're not quite there yet. And I don't really have the capability of reaching a ton of my patients before they get to me because they're often referred by their pediatricians. And so it's okay. It doesn't bother me at all, but it allows me to then when I'm meeting them, I want to have that framework and that foundational visit and answer all the questions they need. But then I say, if you have more questions about birth control choices, or if you have more questions about advocating for yourself, or I did a video about this. And if you want to, you can check out, the Instagram of the period doctor on there. They're like, oh, the period doctor, that's cute. Or they're like 10 and they're like, my mom won't let me get on Instagram. I'm like, I understand. But yeah, that's a great question.
Education is an actual like a printout because I'm curious. I'm assuming just thinking about like the actual clinic flow. And this is something that we always go back and forth on of, is it a link? You're literally writing down, go to theperiod.doctor.com and you're going to find this video. Versus here's a printout from the organization or from the CDC How do you see like opportunities for patient education?
Oh, I do everything. I think that you have to do every approach known to man. So I've got my vulva puppet. I've got like, I'm going to actually show you how to separate the labia and clean this area. I've got diagrams in my patient rooms that me and my nurse actually created, because it was the way in which I give my, this is what a period is, this is the physiology of a period, and this is what hormonal contraception does. And I've broken it into, progesterone and estrogen only and progesterone. So I have diagrams in the room so they can look at it visually, and it has certain cues like this is monthly and this is weekly and this is every day. This is every 3 years. I have those things, but I'm also walking through them and I have a kind of a flow. And so it has a lot to do with the way I learn. I learn by reading, but more so when someone's walking through something and making gestures and kind of has some sort of visual that also accompanies that. I also print out things all the time. I print out things from the North American Society of Pediatric and Adolescent Gynecology, from youngwomenshealth.org. I'm constantly printing things out because I would rather patients have too much good information than not enough and have to be, looking at the misinformation that's online. Because when they do go online, a lot of the times that first Google search or that Instagram search or that TikTok search is not going to get them to someone who's reliable, reputable, who's accurate. And so I do all the approaches, every approach known to man, drawing things, writing it out, a dry erase.
Would be so happy. Okay. I don't know if my internet just dropped and my heart just dropped.
Oh no.
I'm getting it.
Oh, I kind of feel silly that I rushed through this. I was thinking that I was going so over time. My apologies.
No, this is great because you're actually getting a lot of questions that are coming straight to me.
Good.
And I
so
think
much more to say.
a lot of our work, I will say, a lot of our work is this real, authentic engagement with with people, and it's getting all of this information. So something that we sometimes can struggle with is that the term preconception health, it doesn't really sit well with many people, but it also it's also an important, we want people to enter pregnancy if they so choose as healthy as they can be. It also covers decades of someone's life and multiple types of conditions and all people. So sometimes it's hard to not be vague.
Right.
So how do you, when you're putting your content together, because really wellness and health, how do you decide on, what are some really important things that we've got to get covered?
Yeah.
Because
so that's,
because it can be through the roof.
Well, it's amazing because social media is so dynamic that as you start to share and as you start to build your platform, it's almost as if it's like if you build it, they will come. You see that when you're posting something. So let's say the reason the preconception thing came up is because I posted something about Black maternal mortality and some ways in which I felt like people could best combat that, instead of, obviously it's not the patient's responsibility to make sure that they don't die in pregnancy. It's just like, the system has to do better. But when it comes to what you can do, preconception visits are a huge tool, to which people said, well, what's that? And so I'm like, oh my goodness, that's a perfect thing. My point is not being made if I say, oh, use preconception visits and leave the room and they don't know what that is. And so a lot of the times just being present and having those conversations, I start to identify, or people literally gift me, the gaps and the things that I need to cover. And so a lot of that is just 20 people have messaged me and said, I need to explain what a menstrual cup is because I said it in this other post. And so now I need to do that. Or people have said, is the tampon the only thing that's inserted that, would collect or help manage period blood? Or people have said, I just never understood what a pelvic exam was. Or what's that speculum thing again? That's what happens. And so I say, I've got to address that. It's not that I organically just come up with these things that work perfectly for patients. You have to be where they are. You have to be engaging with them and creating a back and forth flow in a safe space to really see what they need. And my patient care in the clinic is so much better because of it. Then I say, there's this thing going around where people think that blah, blah, blah. Or a lot of people actually don't understand this. Do you understand? They're like, no. I even learned from other providers, asking things as simple as, before asking a kid, have you had sex? saying, do you know what sex is? Like, I mean, starting
Yeah.
in the right place. Or is it okay if we talk about your weight today? Do you have any feelings about your weight? Just being a better, more compassionate doctor. And so there's so many bad things about social media, truly, when you think about it and the ways in which it can affect people. It's beautiful to be contributing to the good, and being able to find the good. And so it's hard coming up with content can be very challenging, but the more you're in it, the more you engage, it will literally come to you.
Yeah, it sounds like you're doing a lot of listening, and that does then affect what happens during visits. And I will say, even in my own, they'll do blood pressures, and I'm like, I don't know, is that good? Are those numbers good? I don't know. Okay. Good.
Yeah. And so, I started
for them to validate you. I don't know if the numbers mean.
Yeah, I changed the way I even approach, like I have my clinic intake form. And so I've changed the way I made that so that it could be teaching at the same time. So I would say things like first period, that's menarche, and kind of put in order of kind of how it should occur. And then I say, hey, your first period was at age 10. Did you think that was a little bit early, or did you think that was on time? What did you think? And they're like, oh my gosh, so early. Like, I told people I started my period way too early. I'm like, actually, the normal range is 9 to 15. You were right on time. They're like, oh, yeah. And so you're releasing this thing that this teen may have carried with them for 20 more years, thinking that they started off abnormal. And so there's so much empowerment that you can just get by just listening and seeing that, oh, wow, when I explain it this way, they don't get it, because you have
so touching, because you really are changing. You could possibly, changing someone's life in that visit. They really did carry, like,
I genuinely
believe, I was an early bloomer.
I believe I'm doing life-changing work, and I love it so much. And so extending that beyond my clinic is hugely important.
I'm going to move to the next question.
Yeah.
We have, as you talked about, there can be so much information and misinformation about health on the internet. Do you have any advice for how to be a smart consumer of info, or give advice, or the advice you give to patients?
Absolutely. So a lot of the time when I have patients who are like, well, and I get a lot of TikTok-based questions. If you get in the pool, does that stop your period? I'm like, why would it? Like, and so I said, why would that happen? And they're like, well, they say it on TikTok. I'm like, well, now I'll just ask questions. So who says it on TikTok? Are they a doctor like me, or are they someone else? And why would they know that? And so those are the questions that we just have to be critical consumers. What that looks like is, who is this person? Why would they know this thing? If no one else has ever said this, no one else has ever solved this, and science doesn't support it, why would this be true today? Are they benefiting from me believing this? If me believing this means that I pay for something that I otherwise wouldn't have bought, if me believing this means that I repost something or subscribe to something that I otherwise never would have subscribed to, then it would suggest that maybe their intentions are not quite as pure as we would want them to be. So the people that are good resources are going to be physicians. And it's sometimes confusing because people will use a number of titles like vagina expert. What is a vagina expert? It is nothing. It is not a real thing, And so I know. And so I've tried to, you want to be very cautious because, again, social media has its role of talking to peers. Not everyone has to be, a person with a ton of credentials to be worthy of using social media and sharing their voice. But when it comes to what you take in and what you use to apply to your life and even utilize or trial that could potentially harm you, we really need to be careful. And that's the same way. If if someone promises that this fixes something for every single person in the world, then they're likely not telling the truth, because there's always exceptions. So as a physician, I'm always going to say, this doesn't work for everyone. This works for this percentage of people. If it doesn't work for you, it's okay. There's always going to be a plan B. There's never a catch-all. There's no magic pill for anything. And so the caution when it comes to that misinformation out there has to be something that's continuous, that's constant, and you need a strategy. And if you're not sure, ask your doctor. That's really one of the best kind of, tiebreakers. Like, man, this is sounding really convincing. Just ask your doctor. Ask your doctor, and we should be able to at least give you some guidance. And sometimes I'll say, it might not hurt. There's no reason it should help. But if you feel like you just want to steam your vagina because you think it's cute, sure, don't burn yourself, It's unlikely to disrupt your fibroids or do anything meaningful. But if this just makes you feel calm, I'm not going to shame you. for wanting to seek alternative methods to something that medicine can't solve, right? Because that's the reality of it. The majority of the time, medicine, whatever we've come up with, whatever we're offering, is not satisfactory for a patient population. And so even the desire to look for other causes or other kind of, treatments suggests that there's a gap that needs to be filled. So there's always an opportunity to listen. But I just want people to be cautious and careful. And, if someone has no credentials and no accountability, it's hard to trust them or to do something that could damage your body because they said to do so.
We have two questions that are somewhat related. One of them is a little bit longer, so it's going to take me a minute to read through it first. But the other one is about, so one, a shout out to Sonia Renee Taylor's Radical Self-Love, something that you had just mentioned as well about, does someone gain from your self-love and your joy? So I just want to shout out to that. And then also the question being, so sometimes evidence-based can interfere, the term evidence-based can interfere with cultural norms, and especially being a pediatric or, working with young adults, and, where, grandmother or mom, they do it this way. And this is very much a cultural norm. What do you do to help demystify misinformation that are maybe things that are generational? That have gone way back and they really ingrained in someone's culture.
Certainly. So, that is a big part of what I do, because I really have two patients, right? I've got the patient in front of me and then I've got their parent, guardian, whoever. And there's a lot of grandmothers raising in this world. And so I have definitely encountered that kind of generations old, like that grandmother, just is done with it. So one example is on my intake form. Of course, I'd hand type this intake form, is sex assigned at birth. And so I've got female, male, intersex, and then none. Gender identity, girl, woman, boy, man, non-binary, other, and pronouns. And I had a grandmother get very upset with me for even having this on the paper. And she actually wrote woke bullcrap on the paper. And I was just like, what? I asked the patient, I said, did you write this? She's like, no. Because she knew her grandmother had written it. I went to the waiting room. I said, did you write this on my paper? And she said, yes, because I just don't believe in that. And I said, that's super interesting. This is real. And this is my paper. And you're in my office. And so what I get from that is that you're trying to send a message to me that's actually very disrespectful. So if you want to put down the pronouns that are appropriate for your granddaughter, I can help you walk through that and what that looks like. And she, started saying, well, she and her. I said, look, you already answered them. It's she and her, and girl and woman. You just circled them. I put them on the left so they're the easiest ones to find. That's not a point of arguing. But let me tell you why this matters. There are people out here who do not fit into these categories exactly how you would want them to fit. And it is more important that I acknowledge them and let them know that I care than to make you upset today. And so as long as you're in my office, we're not writing words like that, because I'm going to treat your granddaughter and everyone else in here with respect. Do you understand? And she was like 60 and she's like, well, yes, and I'm sorry, but it was so nuts to me, but you have to address it. So that's one example. Another example is a mom who the daughter was saying that she didn't use tampons or so. I asked, you use tampons or pads? And she goes, pads. And, I was just like, okay, why'd you say it like that, girl? It was a simple question. She's like, I didn't use tampons. And then her mom's like, she better not use tampons. I said, oh, interesting. Why? And she was like, because tampons take away virginity. I said, oh, interesting. Okay, tell me more about that. And the mom kind of sat there and she was like, well, I was told the tampons take away virginity. I said, do you mind if I talk about, this a little bit more? Virginity is not a medical diagnosis. There's a lot of hesitancy that maybe the tampon could tear the hymen. That's exceptionally rare, but it isn't related to actual virginal status. Have you ever wanted to wear a tampon? The patient's just like, I wanted to go swimming. I'm like, all she wants to do is go swimming. This is not a matter that has to be sexualized. It is okay to wear a tampon. And I'm not going to argue with that mother, but I'm not going to lie to my patient either. And so I'm going to say, I'm telling you, as a gynecologist, that this does not harm you. It doesn't take away your virginity, and it is appropriate to manage periods. And we shouldn't shame girls for doing otherwise. If you choose to not use tampons, that's perfect. If pads are your favorite and your jam, you do that, girl. But we are not going to lie in my office for the purposes of perpetuating cultural norms that make us feel better, but they actually harm us in the long run. So those are some of the ways in which I approach it. And it is almost on a daily basis. And it is great because it makes me, I have to choose my words very carefully. I tend to just ask more questions and you really get to the root of it. And at the end of it, I try to resolve things. The majority of the time, the kid just wants to be healthy and the parent just wants them to be healthy. And you can often reach some common ground if you listen and if you try.
Thank you. And I really appreciate the inclusivity that you brought up with especially with the screening questions. That's something also that our team has really tried to adapt and really build and bring into this conversation.
Yeah.
There are probably 10 more questions in the chat, and I think we're getting close to time. And I wanted to give you space to any other wrap up. I wanted to give you the last couple minutes. Any other advice you have to health providers or health teams, or really if there's a public health organization, someone that's that wants to help combat misinformation or share information about COVID vaccines or whatever the topic may be, how to get started and how to really engage and resonate with the public.
Yeah, so I think there is a misconception that the social media world is oversaturated, or I don't have something to bring to this space, or my voice doesn't matter. And it doesn't matter what your organization is doing or who you care for, they need you. And seeing you and your presence on social media, it really adds another layer to your commitment to your community, saying not only am I here for you in this brick and mortar building, I'm coming to you on social media to show that I'm here for you here as well. And I think that the social media aspect of my career and my medical education has transformed me as a provider. It has definitely made me a much better physician to the patients that come in my office. And it doesn't matter that someone somewhere doesn't get it, right? I don't care that there's some executive in my hospital system that doesn't get my social media. There's 70,000 people out there that get it, okay? And it's not that there has to be sheer numbers, but I assure you the impact, the person you will reach, the people you will reach, the person you'll encourage, the person you'll educate, that is way more important than someone who's just kind of like, why do they do that? Why did she post a picture today? She's so self-absorbed. That's not important. Why does she need to have music behind that? Did they have to dance to tell me about? Who cares? It is helping people, and we need to be creative in our approach. The reality is that the world is changing. Social media is where people are. It's how we reach people. It's how we affect change. And if your commitment is to affect change and to be an advocate for people, it's where you and your organization need to be.
And there's a vulnerability to that as well. And so I will say I am so thrilled to be in community with you today, and could not be more proud to have you as a keynote during this Future Forward conference. I felt so inspired by everything that you've shared. I'm sure our team has as well. Thank you again for your time. I so appreciate you being on here and inspiring us and enlightening us with opportunities to really make changes and change people's lives. We can change the narrative.
Yes, thank you so much for having me. I love this opportunity. I am obsessed with questions because I again love to listen and learn. And so if people want to send me questions, please feel free to send them to me on Instagram. I cannot promise that I'll get to you today, but questions about my social media, I'm happy to answer.
We did have a bunch we weren't able to get to, and I will do my best to keep to save them, and hopefully we can answer them. I can send them to you on social media, perhaps.
Awesome. Thank you so much.
Bye.
Bye.
Wow. I mean, mic drop after mic drop, right? Dr. Chambers deserves all the flowers because really, she gave us a path on how to be affirming, really real, set boundaries, and be the best version of a provider that we all can be. So infinite gratitude to her, much love, and please know that we will start our next session in 4 minutes. So take a stretch, nourish yourself, and we'll be right back.
And I just want to, while everyone's breaking, I just want to welcome our next panelist. If anyone wants to do a mic check or Camera check, feel free. Claudia, you look fantastic.
Hi,
I
can you
hear
hear me?
Yep.
Things were freezing, so I'm not sure. Hopefully it doesn't freeze up on me again.
No, you sound and look fantastic.
Okay. Hey, Dr. Koto, how are you?
Hi, I'm doing well. I look a little bit dark. Let me see if I can turn on a couple of lights here. Hold on.
Hi, Dr. Farahi. It's so good to see you.
Hi, Sarah. Hi, everyone. Can y'all hear me okay?
Yeah.
Yeah.
Let's see here. Let me try this.
Leah might be
Can
stretching
you
her
face your
fingers.
window?
What'd you say?
If you face your window, what's behind you?
Living room.
Okay. Fine.
Is this okay though?
Yeah, it's
Okay.
good.
All right. Okay.
And we are taking our wonderful MC for the day and bringing her to our panel. So thank you. And then, like I said, Rio is maybe just stretching her fingers for a minute, and she'll be back on camera in a minute. And I see Dr. Chambers is still here. I'm just going to give her another shout out for giving us lots of ways to get started with our last session, which is great. And this is Rio.
Hi, everyone. So lovely to see you.
And hopefully Natalie will be joining us shortly. There she is. Hi, Natalie.
Hey.
Hi, everyone.
Oh, I'm so excited. What a wonderful panel. We have a great turnout.
Natalie, you're making me homesick looking at your background.
I know. How are you?
How are you?
Good, good. Oh my God, so busy.
Yeah, very busy day today.
But in a good way, I say it's always a good thing because everyone's working together. We're finally sort of figuring it out, but in the right ways, because I think that's where these intentional discussions are happening, like just what you mentioned, Kanika, about relational wealth, and like other countries have been doing stuff like this for so long. Like Australia is such a good example with the Aboriginal cultures and stuff, but we can't get it together here. We can, it's just, is the will there?
Right. Well, we can use this space to create an intention, right? And start to create some new expectations. Well, we're at 2:35. Shall we?
Absolutely. So welcome back, you all. This is our final panel session of the day and our whole conference. It is titled Vision Forward, New Ideas for Advancing an Equity-Aligned Approach to Wellness and Wellbeing. This closing session will be a conversation to generate new ideas for taking this important work forward. Our panelists, by the way, including myself, will talk about their fresh ideas and possibilities for the future based on our current work. We encourage audience members to chat in and share their innovative ideas too. This will be a powerful final session, and it will only be successful if we all are in it together. We hope that after this time together, you all are energized and ready to do better together. Now I will pass my mic to Rio, who will be facilitating our session.
Hello, and thank you, Anna. It is a pleasure to be here. For those of you who've been on the rest of the day, I've been behind the scenes doing graphic recording, and I'm thrilled to bring that into this final session. My role will be to ask questions and share my screen and reflect back at different points. And to kick us off, I'm going to hand it to Sarah to give a little framing for this session.
Sure. And we're going to all introduce ourselves. We have bios online, but I'm Sarah Verbeest, and I am with the School of Social Work at the University of North Carolina, Chapel Hill. And I get to be on the Preconception COIN team. And I'm just so grateful to everyone for their time today. So this is a chance for us to build on the conversation from our first session. And we are going to challenge some assumptions, challenge some words, and put some important questions out there. And then we are going to be listening to some new and exciting work that's happening, new ideas that are emerging, and think about how we can take this work to a different level in our country. So that is our setting. So I'm wondering if we want to maybe just do a quick intro and pass it to each other. I'm going to pass it to Kanika to introduce yourself, and maybe you can just pass it around.
Sure. Good afternoon, everyone. I am Dr. Kanika Harris. I am the Director of Maternal and Child Health for the Black Women's Health Imperative. And should I pass it to Dr. Fofie Akoto?
Sure. Good afternoon, everybody. My name is Dr. Fofie Akoto. I am a physician of internal medicine, currently at Emory University Hospital. I was in primary for about 5 years now, primarily in the hospital, but for the most part, general internal medicine. So I'm happy to bring my perspective to the table.
Awesome. I will make this easier. Natalie, would you like to connect?
Good afternoon, everyone. I'm Natalie Hernandez. I'm an assistant professor in the Department of Community Health and Preventive Medicine and the executive director of the Center for Maternal Health Equity at Morehouse School of Medicine.
And Nargis?
Good afternoon, everyone. My name is Nargis Farahi. I'm a family medicine physician and also direct our kind of clinical program for maternal and child health for the Department of Family Medicine here at the University of North Carolina. I work providing primary care at a federally qualified health center and also direct our inpatient service for caring for birthing patients and their newborns here in the hospital. And I will pass it over to Anna.
An honor to be amongst all these powerhouse of leaders. Well, you all know me because you spent the whole day with me as your MC, but again, Ana Cabello de la Garza, pronouns she, hers, ella. I am a public health social work practitioner and scholar. I work and live in the beautiful mountains of Western North Carolina. I am over at MHEC, the Mountain Area Health Education Center, and I'm excited to get to talking today.
Oh, thank you, everyone. It is fantastic to have all of you on this closing panel. And perhaps one more thing that I can add about myself and role here today is that my background is in public health, and I got into graphic recording because I believed in the power of truly listening and shifting power in terms of what we are recording, which conversations we are recording, and how we're doing it, not just doing it in a memo, in written word. And so bringing that into this closing and thinking about visions is very exciting. So to start with, our first question for you all is, how can we support health in a culture that doesn't help people be healthy? We believe that people don't want to go into pregnancy unhealthy, but they lack access to information, choices, and resources to do so. So how can we support health in a culture that doesn't help people be healthy? I'll invite folks to jump in popcorn style, and Sarah's going to help keep track of who else wants to be speaking and when.
I can start. I think something that I've been, thinking a lot about is that you know, in this society, it's always an either or. Like health is not something you either have or do not have. I think it's about different degrees of health and can be seen as sitting on a continuum that's created. I think we place blame on what people have or not have. And it's a sustained ongoing process between ease and disease, right? I think we need to think about attributing responsibility to systemic, structural, and policy level factors. And we need to lead with justice and fairness. I think oftentimes, again, what we do in this society is tell people what you can't have or what you shouldn't be doing. And we should be leading with fairness. And these are alternate ways of thinking, or we're not blaming you. We know it's systemic, but then these are opportunities. We need to emphasize collective solutions. I think, again, we think in silos. We are individualistic society. We see that more and more with the pandemic and what people's views are. And then we need to center explanation rather than explain, rather than place blame, explain why these factors came to be and how to end them. Because we're always going around in circles talking about problems, but we forget that there are solutions and we can learn from other countries and other systems that are doing really good work and replicating it, but then like leveraging resources together to address to work for the solutions. I'll end there.
I kind of wanted to highlight the part of the question, actually. You said in a society where being healthy really just kind of isn't the priority, or where a society where being healthy isn't the focus. And so I think it's really important to identify that when you're talking about patients' own responsibility for their own health. Very often you have patients, or I would personally have patients who would come in and really expect for me to give them health. So I think the responsibility is on both sides, but also think if people had a greater understanding that you can actually take ownership of your own health by, you know, learning things. And obviously it comes from the other end where resources are available and access and all of those things are extremely important, but also individually for people to understand that something that you have to actively seek. Health isn't just going to come to you. And no one is going to hand you your own health. So you really have to be an advocate for your own health, own overall health and all of the various different aspects, but also empowering people to understand that you do have the power to be healthy. You have the power to maintain your own health and to advocate for yourself in a system where that isn't the priority. So I think a lot of times it's important to look at both ends, but also just giving people the knowledge and the understanding that you do have the power to make yourself healthy, to maintain your own health, and to advocate and making certain that while the other end and politics and everything else might lag behind, of course, giving people to go and, you know, to go get those things for themselves. And when you go into the doctor's office with questions to ask, those kinds of things, and knowing what you have in your own power to facilitate for yourself, I think is really important.
I think that when I think about this question, I think about, you know, traditionally we are siloed in terms of how we think about social issues, policy issues, and then health issues, right? And traditionally, in order to really turn the tide, social and economic policies have to become health policies. They have to work in tandem with each other. So in terms of what Dr. Akoto is saying, that if you are empowered to be healthy and to do that for yourself and your family, it has to be embedded in society where every time you're thinking about a social policy, every time we're thinking about economic policies, what are the health implications of those policies? They have to become health policies in order for us to be, not just empowered, but have the agency to do these things that we are talking about. And until we work more, as Dr. Hernandez was talking about, collaboratively, where every time we're talking about these things, what are those health implications? What does that mean? How does that either move us forward or hinder us in terms of making these things happen is so important.
I think for me as a clinical provider in a community setting, I also think about this question kind of on the individual level as well as in the community setting, and really believe that every person, every individual should have access to comprehensive, really culturally sensitive, linguistically appropriate, accurate health information, and should have the opportunity to really engage in meaningful conversations and discussions that support them in making the best decisions for their health and their life circumstances. And I think that's really essential on that kind of individual level. I also think about the kind of broader social and societal issues, and think, universal affordable coverage of preventative wellness-focused care is really important, as well as sexual and reproductive healthcare services. And those are really critical, but not enough in and of themselves. I think our healthcare teams are siloed, as I think other members of this panel have already noted, and we really need to kind of broaden the definition of those teams to include community health workers, doulas, peer counselors, mental health providers, others, really thinking about which team members might be best equipped to share that information and resources in different situations. And it's not always like the traditional clinical team that is kind of based in the office or the hospital. It really takes a village and requires an all hands on deck approach and a more collective approach than I think the way that we have traditionally approached this in our country and our kind of society. I also just think that centering community-based efforts to meet health needs and incorporating those efforts into our clinical efforts is really important. I think that's another area where those silos can exist, and where kind of bringing people together and integrating efforts and creating synergy whenever possible can make a big difference. And then I think the last thing that I was thinking about as I was listening to the other panelists is that we need to change the culture within healthcare, but also really kind of engage all sectors of society in creating a culture of health. And that means like professions and disciplines that we don't often think about. I think we've been hearing about the power of social media to improve health, and factors like the digital divide, science disinformation need to be addressed, engaging artists and journalists and, education experts, business people, government folks. I think it really is going to take a really like cross-sector effort to really kind of change the culture. So it really is a more health and wellness focused culture than what we have now.
Absolutely. I love the synergy and the interdisciplinary aspect that everybody has echoed so far. I want to go back to the question and think about the power of interrogating something, right? The power of saying, why is our culture like that? Why are we framing health and wellness in XYZ way? Why are these policies and protocols and procedures enacted? And if we would engage in reimagining what's the baseline, what's the standard for health, what is normal when it comes to health, what is not? I think that we have a great opportunity right now, and the pandemic can be a portal, a watershed moment actually, to do our work differently, right? And to foster this culture of wellness. And I think that we can start doing that by engaging in self-consciousness, right? Which is like the ability to understand how society and history have influenced and determined opportunities to define our realities, right? So if we think about it really, the strategies that have upheld us, or not so much thus far, will not be the ones that will heal us. So we need to shift our model from the bare minimum of surviving, right, to fully thriving. Can we, for example, ask ourselves, who is benefiting or profiting from this culture that does not allow us to fully thrive, right? What are the stories that we tell ourselves of what is possible? What are we prioritizing? What are we saying that it's important versus what we're doing? How do we operationalize our values? I believe that we need cultural messages that do not assume shame or blame, that we need cultural messages that are affirming, asset-based, and resiliency informed. So for example, things that I ask myself are like, what if we explore what wellness means beyond healthcare, right? What does health look like beyond healthcare? What if wellness is its definition and its operationalization was created with, by, and for the people, right? Because wellness to me and healing to me is relational and not just transactional. So if we switch it up a little, and instead of having a scarcity mentality culture, what if we had an abundant mentality culture for what wellness can really be?
That was awesome. And comments from the chat, that's a beautiful vision. Absolutely.
Thank you all. And you'll see I'm looking down because I'm just furiously trying to capture your beautiful contributions and trying to grab things before they leave my head. But a couple of things that I want to reflect back to you that I am hearing is, first, there's this kind of movement across the page. Someone started us with this spectrum from disease to ease. And there were also these other continuums that were coming up around the individual moving to the system, to the collective. The idea of a pandemic as a portal and moving from where we are now to where we can be. And I know that this is probably appearing very small and a little fuzzy on your screen. You will get a clearer copy. But in addition to the movement, some of the key themes that I was hearing were around power, responsibility, and agency were coming up. We talked about responsibility of systems and structures. Related to that is the idea that social and economic policies must be health policies. Also, responsibility of people and of those around them to empower folks to advocate and maintain for their own health. But with that comes that question of what is in your power and what agency do you have? Where does that come from? And that brought us also into this power of interrogating where we are now, thinking about who we are centering as we move forward, and really changing culture. So with that, I want to pick up where Anna had left off. She was talking about, what if we had an abundance mindset as we moved forward? What if we imagine something different? Because in the words of Adrienne Marie Brown, in one of my favorite quotes, somebody did imagine the system that we're in, and we can imagine the system, or perhaps lack of system, the ecosystem that we build. So the next question is, words such as at risk and even prevention and healthy present challenges. So healthcare providers are taught to find problems and fix them in a visit. So what are new words and approaches that would better serve people of reproductive age? And Sarah, I'll turn it to you to help monitor who speaks when.
I can jump in. I always like the word protective versus prevention. I think when I think of protective, especially when I think about the crisis in maternal health, reproductive health amongst Black women, the first thing that we are feeling in the within the healthcare system, just in general, just within the society, is that we're not protected. So to use words like, this is around protecting your health, this is around protecting your reproductive health, this is more of a protective measure for you and looking at your long-term health and the health of your children, this is to protect your children, I think sounds better than prevent, because of course, preventing, you are thinking from, not from an abundance point of view or from a deficit, right? So that's just something that comes to mind. Of course, at risk has always been a problem. Words matter, they matter so much. And we know because we spend so much time naming our children, naming, thinking about, who we are. So words really matter. So when you are labeling someone at risk, how that frames how they think of themselves and how they think of their health and what's possible for them, really sets them up from a place of deficit, something that they have to work against. And I'm going to throw it around to use around a better word for at risk. But I just know how it innately makes me feel, especially being pregnant and being at risk because I was pregnant with multiples, or at risk because, I'm over 35. So those things, can make you feel like, it adds an unnecessary level of stress. So if anyone has thought about other words for at risk, I am open to hearing them.
I love the word protective. I think protect is very, very much offensive, whereas preventative feels more defensive, where you're just kind of waiting for something to come at you. Whereas protective is, no, I'm putting up a shield against these things that I know are out there. We know kind of based on the food culture and, work culture and all of the other cultures that we live in, that certain things are almost inevitable. And so, this preventative, what we call preventative care, I think was kind of a default word or phrase, but I think protective is an absolutely great way to kind of, remove that defensive kind of mentality where you're just kind of waiting for something and hoping to not catch it, versus protecting yourself from this thing that is out, is inevitably going to be there waiting for you based on these, this cultural environment, of all of the various aspects that impact our health. But like, for example, like I would see patients, or when I see patients that are young that come in, I would get excited because it's an opportunity for me to educate on how to protect themselves from these that are out there, and maybe identify these seeds of things that might be into not so great practices or not so great, the buds of disease processes that I can identify when they're young. And so identifying or really labeling as protective care, I think would be a great kind of movement in the right direction, because then we can incorporate all of these multidisciplinary approaches to protecting your health, because we don't come out, for the most part, with diseases in place, right? These things that develop over time as a result of our various, whether they're healthy or not healthy, and it's a result of our environment. And people when they're young, as we all know, prenatal health starts way before you're pregnant, but being able to catch people in these budding stages so that they can learn to protect themselves, I think is a really great approach. So thanks for that word. I think I might steal that.
Yeah, I love that. And then I think someone in the chat put opportunity. And I really like that term because I love taking more of a strengths-based approach, and focusing on solutions rather than discussing the risk factors. Although, understanding why there are potentially, instead of at risk, I would say placed at risk, because it indicates and acknowledges that there were outside forces that either not serve the individual person or population well, or have assigned the at-risk level to unwitting persons, right? And so I don't like to use negative terms, but I still like to frame it in a way where people are placed at risk or people were disenfranchised, because it takes the blame out of the individual person and again focuses on these social cultural factors that placed people at the risk that they are, because also sometimes we need to understand what those other factors are that have put them at at a disadvantage. But definitely considering community assets. I like the word hope. I like the word resilience. I think we need more thoughtful examination of what community challenges are and how we move forward. So again, opportunity, hope, protective. I love those terms.
Something just came to me, sorry to jump in again, because I was trying to think about at risk. And like intentional care, like if we say intentional care, or just something else that says that this person needs a special type of care based on what is happening right now. We need to be more intentional about the care that they are in, or so these people are in intentional care. And it makes us think intentionally about the care that we are giving them based on, I guess, the how they are presenting as well. And the word resilience, Dr. Hernandez, I'm starting to challenge that word because I'm so tired of being resilient.
I completely understand. I understand, because it's always like you're forced, like how much more can you take on, right? How much more can you put up that? I think it goes into what we'll probably talk about later, which is that relational health. And why we need to think better about it.
Yeah, and I think I just think, when I think about resilience and a resilience framework, and we are strong and resilient, it always means that we are fighting against something again. And I just feel like it's about how can we make a better society where we can just live and breathe, and we don't have to bounce back against this and bounce back against that, or fight this or fight that. Yeah, that is, we know that it's a natural part of life, but we are at a point where it's just too much. And so now when I hear the word resilient, I start to cringe a little bit, and I'm kind of like, how can, I guess, society be more resilient to protect us instead of the other way around? So I just wanted to throw that out there. Yeah.
I think one other term that I really like is support. I think thinking about how you protect, protective factors, how you can protect someone's health or their pregnancy or their reproductive intentions, but also how you can support those things. And that's something that I try to use in clinical encounters with patients, like, what are your goals for this pregnancy, or what are your goals for your health or your life, and how can we help support that? And really, I like the intentional care. I always think about kind of individualized care, like what does the individualized care for this person look like based on their context and those the factors that come into there. But intentional care is something that I'm gonna try to incorporate as well. I really agree that the term at risk really kind of pathologizes people, pathologizes their bodies and their lives. And so shifting away from that deficit language to really strengths-based language, I think, is important. And that's something that when I'm seeing teenagers and young people in clinic, often we think about screening for risk factors. And lately I've been really starting to try to lead conversations with, like, what's going well? Like, what are you really good at? What have you done recently that you're really proud of? And like leading with those strengths, and then kind of trying to build on those in terms of opportunities to better support wellness and health. I think the other thing that I was trying to think about from Dr. Hernandez's first comment about that continuum between disease and ease is, how do we kind of bring that into our language around kind of risk factors and not pathologizing people's bodies and lives. And so that's just something I don't have an answer to, but I've just been kind of mulling over since that first comment. And then one other thing that came to mind for me is just using person first language. I think when we learn kind of trauma informed care, especially for folks with like substance use disorder, we really think about how important it is to say, like, this is a person who has a substance use disorder, and not that they're substance user or a drug user. And so I think always leading with that kind of like individualized person first language in whatever context, I think is really important too, and making sure that that's like changed in the culture of the environments that we work in as well.
I think it might also be useful to, in addition to leading with strengths for us as healthcare providers, to possibly lead with, what do you see for yourself? Like, what is your vision for your health? And what is your vision for this pregnancy? Considering this is kind of the topic of the conversation, but what do you want for yourself? What is your vision of health for you? And how do I facilitate that for you? Because everyone is a little bit different. And of course, we're talking about this, this disease and ease. I think it's important for people, and as healthcare providers, for us to understand that there's an ebb and flow. There's ease and then dis-ease, and then we might go back between the two, and helping people to understand that there is going to be some of that in life, with your health and otherwise, but really getting like at the forefront of an encounter, having people really tell us what your vision is, and then we respond with how we can facilitate. When you go in and you sign or you fill out the initial form and it says, how many diseases do you have? Do you have this disease, that disease? But there's no space on those forms where people get to express what I want for myself, how I envision my own health, and what I would like to get from you to establish that relationship. We start from a place of lack or a place of dis-ease, rather than a place of, like you said, abundance, or where we want to be. What is the goal? And I think that would be a better place for us to start.
I really love that so much, and just really listening to what patients share and honoring that, and then reflecting that back and kind of using that as the center of the care makes so much sense.
Yeah, and sometimes we need to also take a step back, because some people don't know what that vision looks like. If you've continuously been disenfranchised, if you don't, like I grew up in the South Bronx, I didn't know, until I left to go to school in Manhattan, that there was this whole other world. I know friends that have never been to the airport. So sometimes we don't know what's outside of the world that we're living in every day. And so, I think particularly with some populations, understanding what that vision looks like. And I know sometimes we want the ultimate, vision of health, but sometimes it's so limited, because if you don't know any better, then what do you know to envision? And I think sometimes we have to help people understand, or create pathways of opportunities, or I don't know what I'm trying to say, but help people envision something that they want. It might not look like the ultimate goal of health, but it's like, that's why I was talking about, like, maybe health is envisioned in different ways for people. Maybe it's just having, one fruit a day, or, being able to cross the street and not get hit by a car because there are no sidewalks or stop signs. So I think incrementally for some people, that vision, they don't know how to envision that, I think, and then we would have to interpret it in different ways.
I love the flexibility of allowing folks to dream and interpret and manifest, and also change their minds depending on what it looks like on a day-to-day basis across our life course, right? I also really appreciate the onus and the spotlight being placed on systems that place us at risk. I also really value talking about protective factors. So if we're going to be talking about risk factors, we have the responsibility to talk about what is working, right? And what is promoting health. Can we have like promoting factors as well, right? Can we have like a flourishing measure, right? Like, let's be really real. I truly believe that the degree of trustworthiness and trust is directly related to the degree of progress in healing and wellness, right? So those are new words that are process-based and outcome-based. If our language and our messaging and our services are not trustworthy, we cannot expect people to continue showing up, especially when they're being represented as at risk or deficient or vulnerable, right? So can we change without engaging in virtue signaling or performative allyship, right? Can the systems and those who operate within them follow up and follow through and show up? And when we are talking about like best practices, deconstructing that and unpacking that and saying like, who are we applying that to, right? Like, who are we modeling? Who is being used as a standard or the baseline? Who qualifies as an expert? I really believe that if you're not from a specific community, you really need to practice making space, right? And helping them based on what they want and what they need to lead for themselves, right? And if we can really focus, like it was echoed before, that language matters, like let's stop using the words that place us in deficit. No more vulnerability, right? Like who's making us vulnerable? Why, right? Like, and I would just like to end with, we must remember that it's really all about community, right? And the people, it boils down to relationships, context matters, and we really all just win when we center human rights, right? Because it really was never supposed to be me or mine. It was supposed to be we and ours. And it was really supposed to be us. And I think that it really will require community, all of us as people and not systems, to repair and build a new medicine and a new public health.
Yes, and I think you all will see that you're getting lots of shout outs in the chat and also a yes, Bronx, New York. So Rio, I hope you don't mind if I'm going to pass it back to you, and then I think we're going to go to, because all of you are also not only talking about this vision, but you're living it or trying to create it. So Rio, I'm tossing it back to you, and then we'll.
Thank you. So I'm going to similarly reflect back some of the things that I'm hearing, but also want to invite our speakers and those listening to anchor onto where our conversation is right now, which is around community and relationships, and that will be where we're going next. But first of all, so things here are getting messy and big and small, which is great because the graphic recording reflects the conversation. The ones that are least, pretty and pristine are the ones where really interesting things happened. There, in terms of words, lots of conversation around protective and rooted in this truth that Black women do not feel protected in our society. Protective as being something that we can do offensively instead of being on the defense. Placing the onus on systems and talking about folks who are placed at risk or disenfranchised. Ensuring that we are talking about support for patients' goals and getting rooted and grounded in their visions of health, in ensuring that we are trustworthy for them, being person first, having intentional care and talking about opportunities and hope. And again, with this kind of movement across the page, moving from what is your vision of health for you into, what does that look like? What is over here? What does it mean to be flourishing? What does it mean to allow folks the flexibility to answer that question with dreaming, interpreting, manifesting, and then really interrogating some of the assumptions in the words that we're using, like resilient, and what kind of expectation that is putting on folks. I want to move us into the next question by going back to, I think it was Dr. Harris, and I apologize, I'm looking down the whole time, so I'm not looking at who's speaking. I think it was Dr. Harris who asked, how can society move resources, or I'm sorry, no, it was how can society be more resilient to protect us?
Mhm.
And with that rooting in protection, in putting the onus on society and thinking about the relationships and community that we were talking about, this next question is, what are some new ways of thinking about studying and taking on improving preventive health care and well-being for people of reproductive age, especially those who are often overlooked and suffer from generations of structural racism? How would you spend resources to make change? What new ideas and projects are you working on? And anyone can jump right in.
Okay, so I can jump in. The Black Women's Health Imperative, I've been working with the Kellogg Foundation, and we received a planning grant that really has 3 tiers. One of the major tiers that I was looking at is just the work that we know midwives and doulas offer, and how just an important public health protective factor midwives and doulas are. However, there's no HBCU campus that has a midwifery program. The midwifery space is very white still. And so even though we know how protective midwifery care can be, for those that have a natural and normal pregnancy, what that means within midwifery, that level of care can also be sometimes discordant for Black families or families of color. So what one of the programs that we're doing is we are having a doula program on HBCU campuses. I think we're going to start with Howard and Morgan specifically on the East Coast. An important part of that is just not to train college students to become doulas, but to also look at it as preconception health, so that they are learning about their health and wellness and reproductive health in advance of childbearing. But also 1 in 5 HBCU students are mothers or fathers or have children, are parents. So we want to make sure that they know their rights, they have the resources, and they're also kind of innately building community that hopefully will stay with them when they decide to have children as well. I'll stop there. There are 3 other tiers. We're working on maternal mental health, which is a very important part, and also implicit bias amongst nurses as well, who, as we know, spend most of their time with birthing families. I'll let anyone else jump in. It got quiet.
I'll jump in, and I'm glad you brought that up, Kanika, because that's something as HBUs and in the AUC we've been chatting about. And I think there's going to be some progress around there, as I mentioned to you personally, to chat, that we're actually developing an OB/GYN navigator program to assist women in sort of that life course approach, and training women and actually placing them and thinking about payment reform models and how do women get paid for the services that they're delivering, particularly to the communities that we serve at Morehouse School of Medicine. At the work that we do at the center, at the Center for Maternal Health Equity, centers the lived experiences of Black women. We take a strengths-based approach to health and wellness, looking at holistic, decolonizing, empowering, and protective approaches to health. We are, what we do is fundamental to centering the experiences of our community, relinquishing the power imbalances, rejecting blaming blame upon the communities that we serve for the structural conditions that are imposed on them. We take very much a science and social justice perspective, and this goes into a new grant that we received through WestAd and the National Heart, Lung, Blood Institute, where we're working on looking at what they deem as evidence preconception. I know that Dr. Verbeest and colleagues are calling for a new way of thinking about preconception, but thinking about it in sexual and reproductive health equity. And so we're looking at how do we implement sort of these models of sexual and reproductive health equity in community-based settings. Am I still freezing? I felt like I was freezing for a little bit. Oh, how do we think about it in a way where we can implement programs in community-based settings, focusing on rural Black women, because we know that that's a population that's often forgotten, and then including Black fathers, because if we're thinking about reproductive and sexual health, we're also thinking about their sexual and reproductive health. How do we create relational wealth, as Dr. Harris mentioned in previous conversations, to strengthen those families, and thinking about culturally relevant approaches to weight and then addressing those social determinants of health. And so the project is not necessarily focused on those evidence-based approaches, although we're working on that, but it's looking at implementation and scalability. And so testing these frameworks in a way that can be scalable in a low cost-effective way, but in a way that demonstrates impact and outcomes. And so this is sort of like a pilot funding mechanism. It's like a first phase, and if proven to be effective, then we would scale up. What we appreciated is that HBCUs are often not funded or at the center of a lot of these initiatives. When we work with the populations, we have the trust of the populations. We were created because of the various systems that we're discussing. And so we were really excited that along with UNC and NYU and Tulane, that we received this funding to showcase the work that we can do and the change that we can embark. So thank you. That's just a little bit, there's a lot, but I don't want to take up all the talking.
I think I can share next. I mean, it's like, I'm just wowed by all the panelists. So I will just share a little bit, I guess, about my perspective. I think we are all shaped by our kind of personal backgrounds and experiences. And I think for me, as a first-generation immigrant and a daughter of a political prisoner, to me, the human rights framework really shapes the way that I kind of came into the work that I do, and particularly in caring for people of reproductive potential, that human rights framework of respectful care is really essential. And I think at the center of the way that I try to approach my work and try to kind of understand the impact that we have in healthcare. And so, I work in a federally qualified health center and a public hospital. And so also being in the safety net and serving patients who are often have been overlooked or suffered structural racism or xenophobia, I think that human rights framework feels like particularly important and relevant to the folks that I kind of work with and try to serve every day. So one project that I'm particularly excited about is really learning directly from patients and families to understand kind of what respectful care means to them. I have my own vision of respectful care, and that may not align with necessarily what everyone's vision of respectful care is. And for me to be able to be a part of providing respectful care, I think I really need to truly listen and kind of understand it from the perspective of the people, families, communities that I kind of partner with and serve every day. So this is really kind of aimed at improving recognition and treatment for reproductive age people with hypertensive disorders in a community clinic setting, but really learning from reproductive age people about what respectful care in that context means. And I think the thing that's really exciting to me is not only the focus groups and kind of listening to patients and family members, but then I think that next step are really having community members directly advise and guide our study, and not just as participants, but also as advisors and co-investigators. And that next step is like really invigorating to me as something that I think is like essential in doing this work and trying to kind of do it in a just way. I think the other thing for me is that this pandemic has really underscored the impact of social drivers of health, especially on marginalized community. The community health center I work with is in a rural community in North Carolina, primarily serving Latinx and Black communities. And I think one thing that we've seen is that the social needs and the impact of those social needs on health have been just it's always been apparent, but even more so with all of the disruption that the last year and a half, 2 years have brought. And so we're working with a kind of rural health fellowship to develop a mutual aid model, kind of growing out of our community health center to really try to better address social needs by developing like meaningful community partnerships. And so that's something that I think will be impactful to people of reproductive age, but really kind of all people that our clinic serves throughout the life spectrum. And then I think just getting back to the part of the question is, if I were to make recommendations of where to focus resources, what I would recommend. And I often go back to something that Brian Stevenson, the attorney and kind of social justice crusader, says, and he talks about kind of getting proximate to the problem. And I think that the solutions already exist and exist in the communities that are most impacted by the problems that we're talking about, and really kind of listening and investing in those solutions that are really kind of like coming up from the people and communities whose health we're kind of discussing today is what I think is the most important. And I think I will stop there.
I just wanted to jump in on what you said before I forget, in terms of innately having the needs in our community. In order for us to really fundamentally shape and be successful at that, we have to really address the stereotypes and ideologies, especially pervasive racial ideologies that are sustaining these health issues that we have. And it allows us to not recognize the resources that we have in our community, and it actually makes those communities reject those resources that we have in our community. So I think it's really important, in order for us to bring that out and to listen, until we challenge these pervasive ideologies, we won't be able to recognize those resources and actually use them. And I see that on both ends. For example, intergenerational families, right? That's a resource, that's a relational wealth. And for Black communities, we're often made to be embarrassed by that. We're lazy, we don't work hard enough, we should be independent, having families on our own, right? But that's actually a resource, a protective factor, and it helps us to move forward. Social support is one of the prime indicators of long-term health. So until we can break apart these racial ideologies and these untruths, we won't be able to recognize the brilliance in the resources and opportunities that we do have. So I just wanted to throw that in, sorry.
No, that's wonderful. I'm not supposed to talk, but I just have to, we've also had some support from WK Kellogg and have been in community with really listening to people. And that's what's come up is you get people together, even in a Zoom space, who don't know each other and have a common kind of challenge or something that they're facing together. And it's beautiful what happens. And I think we don't think about like group care or group solutions. We do a lot of, I'm going to tell you what to do and you do it. And I love home visiting and all, but that's like me going to you, as opposed to what about me helping you find the other new parents in your community, and let's bring together and I'll buy lunch. So I love that idea of community that you raised so much. So I just had to do a little like shout out, amen. And so just keeping an eye on time, I want to look over to Anna and Dr. Akoto. Other thoughts to add to this vision or how you'd spend money?
I would just add just a quick thing. I mean, if I had to say how I would spend money, that's kind of my favorite thing to talk about, because the world is, completely open, right? You have all this money, what would you do with it? One of the things I would focus more resources in that regard on is training more general practitioners. As physicians, we all know there's a shortage of physicians, but generally speaking, when my colleagues and we all went into medical school, part of what we ended up thinking about was repaying loans. And when you have to think about repaying loans, you end up having to think about how can you make the most money so you can repay faster. And that typically means you don't go into general practice. And we need more general practitioners to help with protective care, to help with preventative care, to help to focus more of the resources in managing how to protect, like we said, against these diseases. We need more general practitioners. That's kind of the bottom line. We need more primary care physicians. I would also spend more resources on making the primary care hub really a multidisciplinary environment, making nutritionists more accessible, making physical therapy or exercise physiologists more accessible, making prenatal care, postnatal care, making these resources, making these people a part of what you do on a daily basis versus what you do to try to fix a problem after it arises. So I think people resources, but also training general practitioners to kind of help to move forward or make an environment, to create an environment really supports people in their idea of what they consider, health, and also helping to expound people's idea of what health is if there's a lack in that regard. So if we don't have the education to know that, for example, your daily meal is supposed to be comprised of A, B, C, D, and E, and understanding what your story and what your vision is for yourself, I can say, okay, you might benefit from having a nutritionist. And I'd like for you to see a nutritionist 3 months. But in where we are that's not an option, right? And that's an additional expense for someone to have to consider. So if I had to, put money somewhere, it would really be, making an environment where people have access to all various types of care to protect them against disease. And then, of course, training more general practitioners.
Thank you.
Absolutely. I just have to say, I'm so grateful to be here right now. This is giving me so much life and hope for the future. As the daughter of a public health economist, I don't like thinking about spending resources. I like to think about optimizing my investments. And I would like to say that I would directly invest in people and directly invest in the truth, capital T. Mm-hmm. Truth comes before reconciliation, and accountability comes before unity, right? So, for example, when it comes to studies and research, I really would encourage us all to remember that it's racism and not race, right? It's all the isms in reality. If you're publishing on a community that you do not belong to, please elevate leaders from within as co-authors, right? Cite the brilliance of people that have come before you that are part of the community, that have been publishing and working in the front lines, yet may not have the same visibility as you. I really do believe in centering at the margins. Like Dr. Farahi said, those who have lived experience have the solutions. Pay them for it. Pay them for that expertise. Partner with them since the beginning. Don't let this be an afterthought, right? And once you have your results, disseminate those results in a publicly accessible way, right? It doesn't serve anybody for the lessons learned to stay within academia. So I really think that if we co-create intergenerational virtuous cycles, we can do so much better together. And really, at the end of the day, if we're not centering and operationalizing equity across our disciplines throughout the life course, we're actually causing harm.
Amazing. I feel like we could just talk forever. And I just looked at, Rio and I just looked at the clock and we're like, oh my goodness. She's like, when is this done? I'm like, oh my gosh. Sorry. So we are at time, but so we're not going to go and show the picture, but wanted to just kind of leave a space for a final word or a final charge or a final hope. If any of you want to offer that as we close, wanted to just make that last space.
I think my final hope would be for just communities to have the sovereignty to live the lives that they seek for themselves and they seek for their community, to have the support and resources to be there for each other, to have, you know, truth and equity be at the center of that, and for us to really move out the way in order for that to happen, you know. And when you're looking at this across the life course, it just means all the things, right? It means education, it means policy, it means birth, you know, maternal health, it means social well-being, it means care, elderly care, like all of the things that we need to thrive, and that we have the resources to do that. And we don't have to compromise on our identity, our values, our culture, or any of those things, or be ashamed of any of those things to make it happen for ourselves.
Beautifully said. Any other final thoughts?
I'll say that my personal love language comes in the poems of policy and systems change, as well as centering the community. So I would just like to close in saying that I would invite us to reconsider the popular phrase, hashtag living your best life, to really meaning that living it in your own terms, because you are in a just and free and at ease state, right? And that it should be really based on your definition, and the systems, like Dr. Harris was brilliantly saying, are resilient enough to support that thriving for all of us. So if those systems can be reimagined and constructed by, with, and for community, we're all going to thrive.
And I just want to say, be radical, be an ally, speak up, and don't be complicit. Simple.
Yep. Well, thank you so much. This is such a powerful way to kind of both wrap up this convening, but also, you know, some of the investment that we've had from the Maternal and Child Health Bureau in this space, and a wonderful charge for us to offer to them and so many others about how we can continue to take this work a step forward in new and different ways that will get us to bigger and better visions. Thank you, Rio. I want to just totally hug you because you are amazing. I'm going to offer you like the last word, and then we're going to go to our closing session. Any final words? No. Blessings. All of the beautiful drawings will be available open source on our website, and we'll be sending emails to you with all of them easily available, so that we can all take the time and really unpack and think about how we apply this conversation to the work when we kind of punch back in tomorrow morning. So with that, I want to thank all of you. And Kanika would like us to, Phil, could we, Rio, could we show your screen? She'd like to see the final product. I can maybe spotlight her.
Perhaps I should say that I have pages of handwritten notes that aren't on here yet, because as y'all were talking, I was like, I need to organize this a little more. So what you're seeing is that piece, but what isn't reflected on here, which will get added, is from the last question, themes around first the roots of what we need to do in terms of the human rights framework, decolonizing our approach to health, restoring the power imbalances that exist, and then within that, or building on that, themes around who needs to be involved in terms of providing care, who we are training, the role of fathers, how this is being done, and there are actions to take around implementation and access. There are also ways of being with each other. And then there are finally this underlying theme that came out at the very end around sovereignty and truth, and what does it mean, what does it look like to live the lives that you seek, to live life on your own terms throughout the entire life course.
Amazing. That's amazing. And as we move to close, I also want to point out this work is joy-filled. This is amazing. I am so lucky. Like this convening, the beauty of humans and perspectives that have been able to come together. It's the best work I've ever been able to be involved in. And when you have a chance to listen and be in community, it's a blessing and a gift, and it's transformative for all of us to make work a better place too. So I just want to offer I love it, joy and justice. That's a t-shirt. So thank you, everyone. Thank you to our speakers, and thank you to everyone. And I think we are gonna, we just have a few final closing words and gratitudes for our convening. So I'm gonna turn it back to the team. And thank you again to our panelists, and I'm back to you.
Yes, now I'm going to put the crown on or my MC duties right now. But again, thank you for sharing this sacred space with all of these amazing leaders as panelists. What glorious moment to be able to dream together. And with that said, I just want to reflect a little bit on today and say that we really upheld the transformative magic of grasping things at the root and also calling things by their name, of evolving enough to acknowledge that we're here because we can and we must get it right. Today, we were inspired to show up and show out humbly, sustainably, with an intersectional, anti-racist, decolonized way, with integrity, with love, with purpose, with abundance, with righteousness. Not because it's always fun, easy, or fast, but because it is our promise, our legacy, and our collective responsibility. So please, please, please tell us in the chat or the Jamboard what resonated with you today. What inspired you? What are you taking near and dear to you? So let's remember to pay attention, to use our power, because yes, we all have some power, for the greater good. Let your service be a ceremony that dignifies others. I really do invite you to get yourself an accountability partner so that you can move from aspirational and wishful thinking into sustained and benevolent action. Let's get updates. Let's get receipts. Let's get an accountability community. It doesn't have to just be one person. Again, I really would love to thank all of our speakers and participants. Please know that we have put a survey in the chat, so we welcome all of your feedback so that we can continue to do the right thing and the thing right. I really value your partnership and leadership in redefining and redesigning the course in preconception health and its intersection with equity. I really also value that you spent and invested your time with us today. May showing your love be rooted in justice, liberation, equity, harm reduction, ownership, and amends making. May the divine within you acknowledge and center the divine within everyone else. And in the name of human rights, may we build an equitable world that is home for us all. Onwards. Thank you all.
Thank you so much, Anna. And so we just as a team wanted to, a couple of just some things just to know what other work we have going on. This was part of the preconception coin work that we were excited to have the opportunity to gather together our team, many teams across the country, and all of these different speakers to be able to have these important conversations. We're continuing to have these conversations. You see on the slide, we have a webinar series on a variety of different topics, and I can go ahead and put in the chat where you can go ahead and register for the webinars. Some of them are live and some of them are pre-recorded, but they are all available at this website here. It's now available in the chat. And then some other work that we have ongoing that's just important to note is that we have a national preconception survey that's going out to, I believe, almost 2,000 different people across the United States to really understand preconception health, knowledge and behaviors, and what do people want to know about their health and well-being, and how, and really to kind of have a gauge of what is the status of wellness and health equity in our country, and then where can we go from that? What can we learn from their knowledge and their behaviors and their attitudes towards their own health, how they want to be engaging in their own health, and then incorporate that into patient education materials that we're creating. And we've partnered with BCDC. It's a creative agency that's going to help us to also do a lot of focus testing and hopefully create patient ed materials that are around different topics. And there's some examples on the screen of one that had been in draft. We also, thanks to Dr. Amina White, have updated the preconception health provider modules. We have CME credits available for a series of, I believe it's 6, Catherine? 6.
Maybe 5. Sorry,
5.
it's off the top of my head late in the day.
Yeah.
Between Dr. White and Patty Kisan. So.
Yes. And so those are available on beforeandbeyond.org, and you'll see a box for the modules. She's helped us to really take what, the modules that were existing and really kind of blow them up and recreate them. So we're so thankful to her. On the screen, you also see Rooted. They did one of the webinars for us, and we're a wonderful partner. They also helped us draft a blog around perinatal anxiety. And then lastly, the Show Your Love Today website, we're continuing to try to adapt our materials to be linguistically available to different audiences. So we're still testing our Show Your Love Today logo and our campaign and tagline and what that might look like in Spanish, but we do have the Spanish site available.
Thanks so much, Suzanne. And I know we wanted to give a really big thank you again to all of our co-hosts from the Show Your Love team. So just thank you so much, everyone, for joining us and hosting and engaging on social media for this event or the past couple of weeks. You have been amazing and are rock stars all the time. So thank you, thank you, thank you. And thanks again to all of our presenters and panelists. This has been a wonderful conversation. We've really appreciated the time and energy that you put into this. And thank you to all of our participants who made time to join. It has been really wonderful to have you all here and engaging with us. And please do feel free to reach out in the future. So thank you, everyone.
Thanks, everyone. And these all have been recorded. You'll be able to find the recordings of these and likely the slides. You'll also be able to see Rio's material, the graphic designed materials on beforeandbeyond.org/future-forward. But to get the first ping that they're up and live, be sure that you are following us on social media and that you're subscribed to our newsletter. Thanks, everyone.
Thanks, everybody. Have a wonderful day.